Good morning, everyone. Happy Sunday to all, and a warm welcome to Dr. Asmita Singh. Thank you, organizers, for having me chair the session. We are starting with our first session, Oral Mucosal Clues to Systemic Disease. And over to you, Dr. Asmita Singh, for your presentation. Yes, ma'am. You can start the session.
Good morning, everyone. I am Dr. Asmita Singh, founder and chief dermatologist at Kiran Skin Clinic, Patna, and I am going to be discussing oral mucosal cues for systemic disease, how the mouth is a diagnostic window. So many a times it happens in our OPDs that some patient comes to us with a normal skin or hair related complaint, but you generally ask the patient to open their mouth as an afterthought, and there's a mucosal finding, and that leads to a diagnosis. But how often do we really do this? So why does the oral mucosa matter? First, it has one of the fastest epithelial turnover rates in the body. When metabolic or immunologic processes falter, such as in anemia, HIV, or vitamin deficiencies, the oral mucosa shows it early. Second, the high vascular supply makes it an immune-rich environment with constant antigen exposure, making it a frontline detector for infections and autoimmune responses. Thirdly, the distinct regional anatomy aids differential diagnosis. So today I'll just go over different cases which highlight the importance of oral mucosa in managing, in making systemic diagnosis. So let's begin with our first case. A 16-year-old girl comes with her mother for persistent spots on the lips since childhood. No pain, no itching. She has intermittent abdominal cramps, but never sought care. So based on the appearance of the blue back perioral and intraoral macules with faint involvement of fingertips, the lesions don't darken with sun exposure, and symptoms of intermittent abdominal pain, we screened her for polyposis, and she had GI hematomatous polyps. So these mucocutaneous lentigines are a distinctive feature of Peutz-Jeghers syndrome, and which is because of the STK11 mutation. It precedes the gastric hematomatous polyps, and it is visible on buccal mucosa, fingertips. So why this is important? Because making a diagnosis early leads to early diagnosis of this syndrome, which has increased risk of pancreatic, breast, and GI cancers. Coming to the next case, a 38-year-old woman presented with persistent burning tongue since 1 year. On examination, she had a depapillated glossy surface and angular fissures, and on investigation, she had hemoglobin of 6.5 and low B12 levels. These classic findings reflect epithelial atrophy due to impaired DNA synthesis, common in B12 deficiency and iron deficiency anemia. Importantly, the oral epithelium turns over rapidly, so it becomes a sentinel site where erythropoiesis falters. Recognizing this pattern often leads us to detect nutrient malabsorption, chronic GI blood loss, or pernicious anemia early. So if a patient presents with persistent oral burning, we should not straight away rush with antifungals. That burning mouth may be a cry of iron deficiency anemia, pernicious anemia, or even celiac disease. Another case scenario, a 45-year-old man presents with recurrent mouth ulcers and bleeding gums. He reports fatigue, night sweats, and easy bruising for weeks. So the oral cues are spontaneous gingival bleeding, boggy swollen gingiva, multiple non-specific ulcers, petechiae on palate. So what does this look like? Periodontal disease, severe candidiasis, nutritional deficiency, but something is off because the gum enlargement is out of proportion to the oral mucosal findings. So this kind of gingival overgrowth is very common in leukemias, especially acute AML, acute myelocytic leukemia. The gingival infiltration is classic. The ulcers are neutropenia related. The petechia is because of thrombocytopenia. So when gingival enlargement is diffuse, rapid and hemorrhagic, we should think beyond local cause. We can think on the lines of leukemia. Here we have a 28-year-old woman with a photosensitive malar rash and joint pains and recurrent oral discomfort. This was a classic case of SLE with dsDNA positive. When you look inside her mouth, you see erythematous plaques on the hard palate. These lesions can be subtle and easily dismissed as irritation or candidiasis, but the palate is a classic site for SLE-associated oral lesions. So in this patient with systemic symptoms, this oral change can help support the diagnosis and may correlate with disease activity. It correlates with high dsDNA levels, reduced complement levels, and disease flare. So what are the lesions that can be found in oral mucosa of an SLE patient? Painless, shallow, round oral ulcers, especially on the hard palate. The palate is the classical site. Erythematous patches, plaques, lichenoid lesions, OLP-like, often unilateral white stria. Discoid lupus lesions, white keratotic plaques with red rim. Other lesions include petechia, which is because of the thrombocytopenia, xerostomia, which is because of Sjogren's overlap, atrophic glossitis, lupus cheilitis, erythema, scaling of lips. Now this was another patient of SLE. She did not have an ulcer on the hard palate, but she had white stria-like lesions on the lateral border of the tongue. So Wickham striae are basically the classic signs of oral lichen planus. This is a very common thing in our OPD, and most of us recognize this very easily. The different types of patterns that oral lichen planus presents with are these: the reticular, Wickham striae, erosive, painful erosions, ulcers with white striae at margins. Erosive LP has malignant potential and chronicity because of altered P53 pathways. Atrophic, red mucosa, desquamative gingivitis, plaque-like homogeneous white plaque, papular, small white papules, bullous, short-lived blisters. Another case, a 32-year-old man presents with months of painful oral ulcers. He also reports crampy abdominal pain and weight loss, but attributes it to stress. The oral cues are linear ulcers on buccal mucosa, cobblestoning, localized mucosal tags, and mild lip swelling. So are these aphthae, Behçet's, complex aphthosis? But the striking linear ulcers along the vestibule and cobblestone mucosa point strongly towards Crohn's disease. Oral Crohn's can appear years before bowel symptoms, and cobblestoning plus linear mucosal ulcers is very diagnostic of oral Crohn's until proven otherwise. It is important to refer these patients early to gastrointestinal department because early treatment mitigates severity. So these are the oral lesions in Crohn's disease and some systemic symptoms associated of which happen because of Crohn's. Now let's consider a 52-year-old woman with chronic dry mouth and gritty eyes. She says she needs water to swallow crackers. On examination, the tongue is atrophic and depapillated. The saliva is thick and ropey. There are dental caries and angular cheilitis. So these findings strongly suggest Sjogren's syndrome. Xerostomia is far more than a comfort issue. It's a red flag for autoimmune destruction of salivary glands. And the oral cavity shows this long before systemic complications appear. So coming to the next slide, a 30-year-old man comes in with extremely painful mouth ulcers. He's had several episodes already this year. He also mentions genital sores and occasional blurred vision. Now these ulcers are large, deep, and often heal with scarring, unlike simple aphthae. This presentation should immediately raise suspicion for Behçet's disease, a systemic vasculitis. Oral ulcers are the hallmark. When ulcers are too numerous, too deep, too recurrent, think Behçet's. In this case, a 34-year-old woman reports fatigue, dizziness when standing, and salt cravings. Inside the mouth, you see diffuse brown pigmentation across the buccal mucosa, gingiva, and even the tongue. So this kind of widespread symmetric mucosal hyperpigmentation is highly suggestive of Addison's disease. In fact, oral pigmentation often appears before skin pigmentation. So when you see diffuse mucosal darkening, check adrenal function. Due to increased ACTH, There is elevated MSH activity, which leads to this kind of pigmentation, and often the oral pigmentation appears before the skin. So this is another case of Addison's, and even this patient was proven to be of Addison's disease. When blisters signal cancer, the unruly pemphigus, the oral cavity frequently provides the earliest signal of paraneoplastic pemphigus. So our patient, a 56-year-old woman, presented with agonizing mucositis unresponsive to steroids. The oral erosions were irregular, hemorrhagic, and devastating painful. Unlike pemphigus vulgaris, paraneoplastic pemphigus is progressive and recalcitrant. So this is a red flag for underlying malignancy. Even when the skin erosions had healed, the oral erosions were far from healing. So in this case, we could not do the immunofluorescence test, but the patient was a case of follicular lymphoma in remission, and we suspected this paraneoplastic pemphigus as the biopsy showed the features of paraneoplastic pemphigus. Plus, the patient had immediate relapse of follicular lymphoma soon after the pemphigus flare. This is a case report that is given of paraneoplastic pemphigus associated with Castleman's disease in a 13-year-old boy. Now, Kawasaki disease is a classical pediatric diagnosis, provides a striking example of oral systemic correlation. In the oral cavity, the hallmark is a strawberry tongue, prominent erythema with hypertrophic papillae. Lips are dry, fissured, and inflamed. These findings are part of a systemic medium vessel vasculitis with a predilection for coronary arteries. Rapid recognition of mucosal involvement ensures timely IVIG and reducing the risk of aneurysms. Other diseases in which strawberry tongue can occur are scarlet fever, toxic shock syndrome, less commonly vitamin deficiencies. Now, HIV remains one of the conditions with the richest array of mucosal clues. Candidiasis, pseudomembranous, or erythematous is often the first clinical sign of immune decline. Oral hairy leukoplakia on the lateral tongue is almost pathognomonic and signals significant immunosuppression. And violaceous vascular lesions may indicate Kaposi sarcoma, especially in advanced disease or ART-naive patients. So in resource-limited settings, oral findings often drive early suspicion and testing, highlighting their diagnostic value. These are the common infections: oral lesions in HIV, oral candidiasis, oral hairy leukoplakia, necrotizing gingivitis, Kaposi sarcoma, non-Hodgkin's lymphoma, xerostomia, large aphthous ulcers. Syphilis is the great imitator, and the oral cavity is no exception. Primary chancres with the primary syphilis is characterized by the chancre, painless indurated ulcer. Secondary syphilis is characterized by mucus patches, which are shallow gray-white plaques with red borders, may coalesce to form snail track ulcers, and split papules at oral commissures. Tertiary syphilis is characterized by gummas, deep destructive granulomatous ulcers, and palate perforation is possible. So if we see split papules at the mouth corners, we should not just prescribe Vaseline, we can think on the lines of treponemes. Drugs have very characteristic telltale signs in the oral mucosa: erythema multiforme SGS10 present with painful erosions and crusted lips, fixed drug eruption, well demarcated red violaceous patch. Drugs can also cause lichenoid reactions. Drug-induced pemphigus is already there. Drugs can cause angioedema with sudden lip-tongue swelling. Candidiasis from steroids is very common. So this is a case of SGS toxic epidermal necrolysis, the oral lesions. The lesions around mouth of fixed drug eruption. The drug-induced oral pigmentation because of antimalarials, minocycline, zidovudine, chemotherapy, heavy metals causing blue-black gingival line is a very characteristic feature. Pemphigus, I need not elaborate, it is a very common, everybody knows. The painful oral erosions, they are the earliest and most common feature. Fragile blisters that rupture quickly, they are rarely seen intact. So these are some, this is just a case of incontinentia pigmenti, and when we saw the oral lesions of the mother with peg-shaped teeth and oral conical delayed eruption, anodontia, delayed eruption of teeth, peg-shaped teeth, and missing teeth, This helped in confirming the diagnosis of incontinentia pigmenti in the when the child was just in the vesiculobular stage. This is a lesion of cutaneous leishmaniasis. So quick diagnostic table, lentigine suggestive of Pew-Jagger syndrome, boggy gums, think of leukemia, linear ulcers, think of Crohn's, palatal erythema, think of SLE, major aphtha, think of Behçet's, diffuse pigmentation, think of Addison's, atrophic tongue, think of B12 iron deficiency, hairy leukoplakia, think of HIV. These are the various investigations that can be done when you are examining the oral mucosa and thinking the differentials. So to conclude, the mouth as a diagnostic window is a mirror to systemic disease. Oral cavity reveals systemic disease early. We should look for patterns, ulcerative, pigmented, inflammatory, xerostomia. Oral examination should be a part of systemic workup, and a 5-second oral exam can save you hours of diagnostic confusion and at least 3 unnecessary biopsies. Thank you.
Thank you, Dr. Asmita, for that presentation. And this has led to us to know how important the oral mucosa examination is. It's a Pandora box of our diagnosis, in fact. And you have highlighted the importance of examining each and every corner of oral mucosa, from the lip to the buccal mucosa, to the gingiva, to the palate, to each and everything. And you have covered it, everyone. If anybody has any questions?
Yes, sir. Okay. So most of the lesions in oral mucosa are benign. There are very few conditions which lead to malignancy. Like, I have not gone in that area. Actually, I have not gone in the malignant part today. But oral, infections, autoimmune conditions, all these are benign. They are not malignant. No, sir, I have not touched that. Yes, sir. Okay.
Which presents as in periodontal disease-like presentation.
Okay.
So in certain condition, so then we have to differentiate it by looking at the X-ray, looking at the floating teeth, which is very common in that condition.
Yes, sir, you're
so
right.
So in pediatric, you mentioned about the Kawasaki, which is the most common thing.
Yes,
but Kawasaki, usually we get confused with a scarlet fever. Actually,
yes,
many
sir.
cases we have found out that we suspect about, we think that it's a Kawasaki, when it turned out to be a scarlet fever.
Yes, sir.
So we have to be keep in mind that scarlet fever is the most important diagnosis, differential diagnosis in case of pediatric cases.
Yes, sir.
Okay, thank you.
Thank you
and
for
your
the
presentation was
excellent
excellent. Actually, you have covered most of the part. Thank you.
Thank you, sir.
If there are no more questions, I think we can wind up the session. Dr. Asmita Singh, thank you.
Thank you, ma'am.
Thank you so much, ma'am, for inciting session. I would request our chairperson and speaker to please collect their memento. For the next session, I would like to invite Dr. Shwetalina Pradhan, ma'am, to please chair the session.
So I will like to welcome Dr. Kananwala Sao. She is Associate Professor in Department of Dermatology in IMS and some hospital too. And she had a lot of publication and presentation to her credit. So she is also Assistant Editor of IJPD, reviewer of many reputed journals. And her special interest is pediatric dermatology, clinical dermatology, leprosy and dermatopathology. Over to you, Dr. Kannan.
Thank you, ma'am. First of all, good morning to all. And I want to thank the organizing team for giving me the opportunity. So I'll start. So my topic is here, approach to the primary immune deficiency diseases in a child. So first of all, I want to give you a case scenario. This is a recent case we have seen in the OPD. This is a 12-year-old female who presented with recurrent candidiasis and viral episodes. You can see herpes infections upper the back, and also herpes zoster infection previous episode, and also monilial intratigo, and along with tinea fungium. So what is the diagnosis? The diagnosis is very easy here, multiple viral infections and along with candidal infections. But should we stop there by treating it? Yes, she has visited many hospitals and taken many antifungals and many antibiotics. But what is the response? The patient did not respond and came to us. There are around 4 to 5 episodes per year. So there is something to think beyond it. What is that? That is some immune deficiency is going on that child. So I will cover classification, clinical clues, and some essential workshops needed for the PIDs. So before jumping into the primary immune deficiency, first of all, we should rule out the secondary immune deficiency causes like HIV, malnutrition, or any protein losing conditions the baby have, or any chronic illnesses like diabetes, malignancies, or she is on any immunosuppressive medications. Then coming to the proper definition of PID, PID means poor or absent function in one or more component of the immune system. It is genetic in origin and there is heterogeneous phenotypes with variable symptoms. So what the patient present here? Patient is susceptible to infections and also other manifestation of immune dysfunctions. So we should remember the acronym of M. What is M? We should look for allergy. We should look for immune conditions, that is autoimmune conditions like SLE or DLE, whether present in that patient. And we should also search for the malignancies. The prevalence of PIDs are now growing and there is more than 350 PIDs are known to us. So there are some myths that PID children are generally hospitalized many times and they are also diagnosed in the childhood, but that is not always true because more than 30% of PID cases are not hospitalized at all and diagnosed only at OPDs only, and more than 40% are not diagnosed till adulthood. And the important thing of PID to the dermatologist are that 50% of children present with PID with skin manifestation. So there is a crucial role for the dermatologist to early suspect the disease so that we can better manage the cases. So we should remember the acronym of Garfield, not girlfriend. What is Garfield? So if we are getting this type of conditions in a child, then we should suspect a PID. If there is some chronic granuloma in the baby, if there is a certain associated autoimmune diseases along with infections, if we are getting recurring fever, inflammation, requiring severe hospitalization, if there is unusual eczema, what is unusual eczema? If it is not treated with conventional eczema treatment or there is severity which is persisting long, then we should suspect a PID. Whether PID is associated with this baby, then some of the lymphoproliferation also we should look out. And chronic inflammatory bowel diseases we should also search for. Then there are many warning signs. We should remember these 10 important warning signs in case of PID. First of all, the recurrent otitis media, which should be more than 4 per year, severe sinusitis, severe pneumonia, antibiotic treatment more than 2 months per year, and sometimes there is need of IV antibiotic to clear the infection. And one more important thing, we should also take the family history always, because some of the siblings may be autosomal recessive or may be manifested in a milder form. So we should take the history of family members. Then we are telling infection, which type of infection really? So we should remember the acronym SPOR. Means the infection is always severe, it is persistent, it is unusual, and it is recurrent. Then the infective organisms also put a signature which PID we are dealing with. If the baby is getting infected more with the capsulated organism like S. influenzae and meningitis, then we should think of either antibody defect or there is a complement defect. But if the baby is getting more of the bacterial infections like S. aureus or candidal infections, then we can think of either phagocytic defects like CGDs or leukocyte adhesion deficits, means there is defect in the neutrophils, because neutrophils are the first line defense in bacterial diseases. So we should look for these conditions. Then this is the IUIC classification of PID. This is very difficult to remember, but you should remember that the category 3, that is predominant antibody deficiency, is the most common. Besides this, generally we get patients rarely immune deficiency affecting the cellular and humoral immunities, that is severe combined immune deficiency. Besides that, we should also know the CID associated with syndromes like Wiskott-Aldrich, ataxia telangiectasia, etc. Besides, there are other defects like congenital defects of phagocytes, defects in intrinsic innate immunity, autoinflammatory syndrome, complement deficiency, bone marrow failure, and phenocopies of PIDs. So I want to simplify. If you are getting a PID case, then you think whether there is an innate immunity deficiency, that is phagocyte defect, complement defect, or NK cell defect, because they are responsible for innate immunity, or whether they are in adaptive immunity defect, whether B cell, T cell, or combined. So you will think in that line, and adequately you will go for investigations. So first of all, disorder of adaptive immunity. The most common, already I have told, the antibody mediated one is the most common. In that category, you will find whether there is selective IgA deficiency or common variable immune deficiency or X-linked agammaglobulinemia. So in this broad category, there will be more of the infections with encapsulated bacteria. The baby will present with recurrent episodes of pneumonia, go to the pediatricians, and also come to the come to us with severe infections, bacterial infections. Then if the CBID, you can also search for autoimmune diseases, and there is also risk of malignancies. So first of all, the most common is the selective IgA deficiency, which presents more than 4 years of age and associated with allergic and autoimmune diseases in 20% of cases, and also associated with IBD and celiac disease. The important diagnostic criteria here, you will do a serum IgA level which will be marked reduced, that is less than 7 milligram per deciliter, whether IgG and IgM are normal in this case. So the baby will present with recurrent sinopulmonary infections along with other infections. Then CVID, in this case you will get the pan-immunoglobulins like IgG, IgA and IgM. All will be reduced, but the B cells will be present. Here also you will get that similar clinical feature, but in laboratory you can only distinguish whether it is a IgA disease or whether it is a CVID. Then another entity is selective antibody deficiency. This is very rare, but it generally presents after 2 years, and the diagnostic criteria here is there is isolated polysaccharide antigen which is deficiency. Then coming to the T cell immune deficiency, it may be interferon gamma or interleukin 12 or AIRE mutation. In AIRE mutation, you will get endocrinopathy along with this mucocutaneous infections. Coming to syndromes that all we know from PGs, that Wiskott-Aldrich syndrome is generally associated with thrombocytopenia along with recurrent viral and bacterial infections. Ataxia telangiectasia, it generally presents with cerebral ataxia along with multiple telangiectasia over the eyes. Then Dyeser syndrome, you will get hypoparathyroidism and cardiac abnormality. So here you can see this is a photograph, severe eczematous lesions along with herpes zoster. So the baby is possibly a case of Wiskott-Aldrich syndrome. Here in the eyes you can see visible telangiectasia. The baby is a case of ataxia telangiectasia. So here the typical faces, you can see cleft lip here, and the baby is a Dyeser syndrome. Here in the Dyeser syndrome you will look for the other associated anomaly. Now coming to the another T cell and B cell, both combined deficiency, severe combined immune deficiency. This type of conditions generally baby present with less than 5 years, and there is chronic diarrhea, failure to thrive, and the skin rashes are mainly scaly erythematous, and the baby present with severe infections along with erythroderma. Here the diagnostic criteria, there will be all pan-immunoglobulins will be reduced, along with there will be lymphopenia, both antibody mediated and T cell mediated. Also, you will get marked low NK cell activity in this condition. So, this is an alarming condition, and we can correct this condition by bone marrow transplantation or gene therapy by referring to the higher centers. So, in this case also live attenuated vaccinations is contraindicated. Then coming to the other rare conditions like DOC8 deficiency, if you find a baby with extensive or disfiguring viral warts, then think of there is DOC8 deficiency and do a IgE level. You will get the elevated level of serum IgE. There are other conditions like CD40 ligand, major histocompatibility complex class 1 deficiency, where you will get necrotizing granulomatous skin lesions. Then certain DNA repair defect we all know: ataxia, telangiectasia, ligase 4 syndrome, CID with microcephaly, growth retardation and sensitivity to ionizing radiations, Bloom syndrome, then dyskeratosis congenita. Bloom syndrome, all of you know, this is common: photosensitivity, malar rash and hyperpigmented macules will present. And dyskeratosis congenita, oral leukoplakia, ulceration, reticulate pigmentation and nail dystrophy. Along with that, these babies can get multiple severe and recurrent infections. So, this is a hyperpigmented lesion in Bloom syndrome. Here you can see ataxia, telangiectasia. Here you can see perioral macules, classical of dyskeratosis congenita. And here you can see severe nail dystrophy by the fungal infection in centromeric instability, facial dysmorphism syndrome. Then immune dysregulation if associated with hypopigmentation, then think of these conditions like Chediak-Higashi, Griscelli, Hermansky-Podolka syndrome, IPEX syndrome and autoimmune lymphoproliferative syndrome. In autoimmune lymphoproliferative, we will get vasculitis or urticarial lesion along with lymphadenopathy, along with multiple episodes of infections. In IPEX syndrome, there will be neonatal eczema, early onset diabetes and autoimmune enteropathy. We should remember that. And Griscelli and Chediak-Higashi, all of you know, here in Chediak-Higashi, oculocutaneous albinism along with partial albinism. What is partial albinism? Partial albinism is hypopigmented lesions which are not clear, but when closely examined over the penile lesion or over the periareolar lesion, it becomes clear. Then Hermansky-Podolka syndrome, oculocutaneous albinism and neutropenia you will find. So, this is a partial albinism in case of Chediak-Higashi. This is a case of, you can see, silvery tint Griscelli syndrome, and this is a case of linear IgA disease in fast deficient autoimmune lymphoproliferative syndrome. Then disorders of innate immunity also, phagocyte defects, there are 3 to 4 syndromes in phagocyte defects. The most common is the CGD, chronic granulomatous disease. Here, along with infections, you will get granuloma. And in case of hyper IgE syndrome, previously called as Job syndrome, there will be chronic dermatitis along with failure of thrive and failure to shed the primary teeth in this patient. Another condition is leukocyte adhesion deficient, where in this case you will get peripheral neutrophilia, but the neutrophils will helpless to combat the infections. Here you will get leukocytosis, periodontal disease and delayed wound healing. And there is one important history we will take, there is delayed separation of the umbilical cord in the baby. So, in the CGD is also another important thing, in the peribulbar you will find granulomatous lesions. And LAD, there will be multiple abscesses, especially perianal, periodontal abscesses you will get in leukocyte adhesion deficit. Then if there is SLE or DLE-like syndrome along with capsulated organism infections like severe pneumonia, you can think of complement defect, whether it's an early complement or late complement defect. Then defect in other innate immunities involve an NF-K beta related immune deficiency, toll-like receptor pathway, Huym syndrome, AD or autosomal dominant hyper IgE syndrome and chronic mucocutaneous candidiasis. So, in all the conditions you will get severe skin infections also, skin, scalp and along with some associated features like conical teeth and absent sweat glands in NF-K beta related immune deficiency. And Huym syndrome, there will be severe mucocutaneous warts along with hypogammaglobulinemia and neutropenia. And in CMC you will get ectodermal dystrophy with onychomycosis, superficial mucocutaneous candidiasis and oropharyngeal and perineal candidiasis. So, in CMC also there is lack of T helper cells Th17 cells, which is very essential to combat the bacterial infections also. So defects are gain in function of STAT1 mutation, generally responsible for chronic mucocutaneous candidiasis. Sometimes patients with CMC also look for abscess. What is abscess? You look for other polyendocrinopathies also. So as dermatologist, our approach should be, we should look at the skin, whether there is a infectious disease, infection skin lesion, or a non-infection skin lesion. So in infection skin lesion, if there is a furuncle, abscess, then think of the neutrophilic defect. If there is viral warts are itself never a diagnosis of PID. But if the viral wart is rapidly growing, if it is larger in size or extensive, then think of Wiskott-Aldrich, DOC8 or CD40 ligand defect. Similarly, if you are getting mucocutaneous candidiasis, persistent, recurrent, then think of severe combined immune deficiency or CMC. Similarly, if you are getting eczematous skin lesions, you can think of Wiskott-Aldrich and ataxia telangiectasia. 1 minute, I will finish. If you are getting erythroderma, then think of SCID. And if you are getting SLE-like, DLE-like, I have already told, you can think of complement defects. So laboratory investigations, after accordingly you can do a serial CBC along with all the immunoglobulins, serum immunoglobulins, and flow cytometry will guide to diagnosis. And lastly, confirmative, you can do a HLA typing or genetic study. And there are some functional tests, but recently these are not available, but we can think of sending the specified genetic centers which are doing this type of test. Then coming to the treatment is always a supportive and prophylaxis, and regular immunoglobulin substitution has changed the prognostic significantly in CBID cases. Similarly, hematopoietic stem cell transplantation or gene therapy can change the SCID, severe combined immune deficiency cases. And genetic counseling is a must. That can prevent the pedigree to get this disease. So our case, what we got, there is CBC is normal, peripheral smear we do normal, KOH you can see there is severe budding yeast because there is mucocutaneous candidiasis. Ultrasound, abdomen, pelvis, all the systemic investigations were normal. Complement and serum immunoglobulin levels, IgE, IgG, IgM and IgA all came to be normal. This rule out the antibody mediated defect. Also we have done lymphocyte subsets that shows there is low NK cell with high CD19 count along with other T cells or other things are normal. So this also rule out the severe combined immune deficiency. So we did a genetic testing which came out to be STAT1 mutation positive, which is most commonly occur in CMC, what I have told before, chronic mucocutaneous candidiasis. So our diagnosis is chronic mucocutaneous candidiasis with novel STAT1 mutation. This is the follow-up of this patient. You can see the patient is doing well and receiving genetic counseling because we cannot do any specific treatment to this patient, but we are giving antifungal prophylaxis to prevent the recurrences. So in conclusion, we should first of all, before jumping to the PIDs, we should rule out the secondary causes first. Then recurrent infections, we should think of allergy, autoimmune conditions and malignancies. Then clinical suspicion and guided investigations is the rule. But always genetic analysis we cannot get from retrospectively. First clinically you suspect, then you would do a genetic and do a clinical genetic correlation to reach a diagnostic specific diagnosis. And appropriate antibiotic prophylaxis along with infection control measures are the mainstay of treatment in PIDs. So these are my references. Thank you.
Thank you, Dr. Kannan, for an elaborate presentation and very nice case. Did you publish it?
Yes, ma'am.
Did you publish the case?
No, ma'am.
Publish it.
Okay.
Thank you.
Thank you, ma'am.
Thank you so much, ma'am, for such an enticing session on such a difficult topic. I would request our speaker to please collect her memento. Proceeding forward, I would like to invite Dr. Amit Kumar sir to please chair the session.
I now invite Dr. Dheeraj to kindly deliver his presentation. Dr. Dheeraj is Associate Professor at NSMCH Bihta and consultant at Dermawave Clinic. And the topic of his presentation is acne in females, hormonal and lifestyle configuration.
Thank you, Amit. Very good morning to everyone. Myself, Dr. Dheeraj, and today I'll be talking on acne in females, hormonal and lifestyle configuration. Acne is most common condition. In fact, it's a worldwide top 10 disease in the world. It occurs in the areas with densely packed hair follicles, such as the face, neck, chest, back, shoulders. Acne typically begins after puberty, when androgen activates the sebaceous gland. Around 80 to 90% teenage affected by some degree, but till the age of 25 years, most of the lesions are resolved. In some females, like 12% of the female continue to have acne until the age of 44. Pathophysiology, acne is basically exclusive follicular disease with the primary abnormality being comedone formation. Comedone formation, it occurs produced by the impaction and distension of follicles with the keratinous plaque. This keratinous plaque is produced by hyperproliferation and indifferentiation of the keratinocyte. The nature of this proliferation is not known, but few pathological part like increased androgens, genetic susceptibility, increased virulence of Propionibacterium acne, inflammatory cascade, all contributes to the formation of acne. When these factors acts on the sebaceous gland, this little sebaceous gland turns into the disfiguring acne. Today I'll discuss on androgens and lifestyle modifiable factors. So who is the main driver? Main driver is actually hormone. Among the hormones, androgen, which is primary hormone stimulating sebaceous gland activity and size. Before going into the androgen activity, we will discuss few points about progesterone, which is protective in acne formation. Progesterone is a competitive inhibitor of 5-alpha reductase and might be expected to reduce gland activity. Estrogen in high doses decreases the size of sebaceous gland and reduces sebum production. Insulin, high insulin level and insulin-like growth factors causes acnegenesis. Now, role of androgens in pathogenesis of female. The main androgens linked to acne are testosterone, a strong androgen produced in the adrenal glands and gonads, dihydrotestosterone, a more potent form of testosterone, which is formed by the enzyme 5-alpha reductase. Dihydroepiandrosterone sulfate and androstenedione, it's a weaker androgen mainly produced by the adrenal glands, which can be converted to the more potent testosterone and DST. Hyperandrogenism favors the development of acne by increasing sebum production, but mainly by the altering sebum lipid profile. Androgen receptors are present in the pilosebaceous unit, mostly over the dermal papilla, the outer root sheath, and sebaceous gland. At the same site, 5-alpha reductase enzyme are also present that converts testosterone to dihydrotestosterone, thereby amplifying local androgen activity. In addition, the skin expresses all necessary enzymes to convert dihydroepiandrosterone sulfate that changes into the dihydrotestosterone, that is more potent form of androgens. There are alternative pathways for androgen production apart from the above mentioned androgen production pathway. New pathway produces 11 oxoandrogens that is also in adrenal origin, but there is no data on oxyandrogen level in adult female. So more studies are needed to understand the mechanism of 11 oxyandrogens. Aromatase has a protective function on acne because it decreases the activity of androgen by aromatization. Aromatase role into reduce the amount of circulating androgen by the converting them to the estrogen. So ratio of androgen to estrogen is a governing factor in severity of acne. If androgen to estrogen ratio is more, there will be more severe acne. Now coming to the lifestyle and other modifiable factors, these factors can itself causes acne, can predispose certain person to the acne, and they also help in modulate the acne prognosis, their course, their severity. Coming to the first, the diet, it's the most important factors in treatment of any disease. In fact, this is the first question when patient asks you what to eat, what not to eat during the acne treatment. But there is paucity of randomized controlled trials examining the link between diet and acne due to numerous possible co-founding factors. But few studies have shown that the high glycemic index diet is directly associated with the acne. One study has shown insulin-like growth factors level were found to be significantly decreased who take low glycemic diet. One other study shows vitamin D deficiency was significantly more common among patients compared to the controls. Omega-3 fatty acids, gamma-linolenic acid supplementation were positively controlling the acne severity. This flow chart shows effect of diet. Western diet rich with high glycemic index or rich with dairy proteins can increase the insulin-like growth factor signaling pathway, inducing keratinocyte and sebaceous proliferation, lipogenesis, thereby increasing the androgen synthesis. These are the few reference points where they have found the association between acne and dietary intakes. Body mass index, numerous studies have examined the relationship, but none of them is very confirmatory. One studies from India shows contradictory data. They have found that acne is more during high BMI, but one says high BMI with less acne. Stress, smoking, and sleep deprivation. Stress usually increases cortisol and adrenal androgens, thereby boosting oil production. In support of this observation, a study found that students were found more prone to acne during exam, but their severity decreases during the vacations. Smoking can lead to adverse effect on the skin due to alteration in the skin macrocirculation, keratinocyte and collagen and elastin synthesis. It also causes alteration in sebum composition through decreased antioxidants. Mature women who are persistent smokers seems to have a very particular type of non-inflammatory acne characterized by comedones and macrocomedones. In sleep pattern, there is weak evidence that shows sleep deprivation or insomnia can cause acne. Any form of physical insult, be it chemical or physical, can cause acne. Ultraviolet radiation may promote acne on sun-exposed areas. Cosmetic use, especially overuse of cosmetics or cosmetic products which are comedogenic in nature, can produce acne. This table shows lifestyle and environmental factors and their strength of association with acne. So diet, moderate for glycemic index and milk product, but low for other foodstuffs. BMI, low. Smoking, high for comedonal and acne in mature women. Alcohol consumption, psychological stress, cosmetics have low strength of evidence. Sunlight, lack of sleep has low strength of evidence. Seasonal factors, very high strength of evidence. Now, when to suspect hormonal acne? Not all the acne patient needs to do for all these battery of tests. Acne is basically a self-limiting condition, and most of the acne respond very well to conventional treatment. So hormonal investigation needed in those patients who have therapy-resistant acne, those who develop late-onset acne, pre-pubertal acne, history of premenstrual flare, stress-exacerbated acne, associated sign of hyperandrogenism, sign of virilization, and sign of hyperinsulinemia. The prerequisite for hormonal investigation, they should be off for oral contraceptive pills or any other hormonal therapy for at least 1 month before testing. Test should be performed at the onset of menses. Fasting sample should be preferred if the patient has amenorrhea. Hormones exhibit diurnal variation, so better to take early morning sample. Diagnosis: a comprehensive reproductive history including menstrual cycle, hormonal and ovarian sonographic evaluation is needed. The presence of other possible cutaneous sign of androgen excess. Measurement of androgen in blood should be performed in all women with adult acne. Circulating free testosterone as well as total testosterone should be taken. Now, coming to the which hormone first. So, there are a lot of hormone changes. So, first hormone is dihydroepiandrosterone sulfate. The elevation suggests adrenal source. More than 800 says adrenal tumor. If the elevation is mild, like 4,000 to 8,000 nanogram per ml, consider congenital adrenal hyperplasia. Now, going to the next parameter, which is total and free testosterone. Testosterone, raised testosterone is ovarian in nature. Total testosterone, if more than 150 to 200 nanogram per deciliter, indicates an ovarian tumor. Mild elevation suggests PCOS. Further evaluation for PCOS, we do LH-FSH ratio. If greater than 3, it is PCOS. Ultrasonographic evaluation, and if free testosterone is elevated in all form of hyperandrogenism, but can be useful when there is SHBH dysfunction. SHBH is sex hormone binding globulin. If the level of SHBH decreases, the free testosterone increases. That is relative state of hyperandrogenism. Prolactin would be raised due to hyperprolactemia. Serum cortisol, adrenal neoplasia, fasting and postprandial insulin. Now, coming to the which gland shows hyper excess of androgen, one should either do a ACTH stimulation test or dexamethasone suppression test. Ovarian sources fail to respond to this test. Now, coming to the hormonal therapy for acne, most of the hormonal therapies are mainly directed at either suppressing ovarian or adrenal source of androgen or blocking the activation and action of androgens in sebaceous gland. Now, suppressor of ovarian androgen secretion is oral contraceptive pills are most effective. So, ethinyl estradiol suppresses the ovarian production by androgens by suppressing gonadotropin release from hypothalamus by negative feedback effect. Low dose estrogen is usually combined with various progestin to avoid risk of endometrial cancer. It is administered from day 1 of menstrual cycle and given till the age of 21 days, and this cycle repeats for the next 5 to 6 cycles. Absolute contraindication for using oral contraceptive pills: pregnancy, current breast cancer, breastfeeding less than 6 weeks postpartum, age more than 35 years, diabetes with end-organ damage, diabetes more than 20 years duration, major surgery with prolonged immobilization, active viral hepatitis, severe decompensated cirrhosis, and liver tumor. Cyproterone acetate is a progesterone anti-androgen that also blocks androgen receptor. It can be given 50 to 100 milligram twice daily. Gonadotropin releasing hormone analogs inhibits ovarian androgen production by blocking the cyclical release of LH and FSH. They are available as nasal spray, subcutaneous injection, intramuscular depot injection, monthly subcutaneous implant. Suppressor of androgen secretion. Glucocorticoid can be given. Low dose prednisolone or dexamethasone. Nighttime dose suppresses adrenal androgen production. Glucocorticoid may also be used in acute flare or in very severe acne of few weeks. It will reduce sebum production by 50%. Androgen receptor blockers. Spironolactone is an androgen receptor blocker, inhibit 5-alpha reductase and aldosterone antagonist. It has not formally been approved by FDA. It is administered in the dose of 25 to 100 milligram twice daily. Flutamide is an androgen receptor blocker. It has been used in the dose of 250 milligram twice a day. Fetal hepatitis is a serious side effect. 5-alpha reductase inhibitor, it inhibits the 5-alpha reductase that converts testosterone to DHT. It can be given in the dose of 1 and 5 milligram per day. Insulin sensitizer, metformin is used, especially in the acne association with PCOS, hair and syndrome, obese patient, or biochemical evidence of hyperinsulinemia. Dose is around 500 to 2000 milligram per day. There is no particular limit to duration of metformin, but if people are not responding well to after 6 months, you can stop the treatment. Most side effects are dose dependent. Now, coming to the monitoring guidelines of hormonal therapy in acne, oral contraceptive pills, as such, there is no need for monitoring, but first rule out the absolute or relative contraindication. Sapropterin acetate, periodic monitoring of liver function test and clotting factor, gonadotropin releasing hormone, dual energy X-ray absorptiometry, DEXA scan for orthopaedic changes, glucocorticoids, periodic monitoring of blood pressure, electrolytes, blood glucose and DEXA, spironolactone, periodic monitoring for hyperkalemia, low blood pressure, electrocardiographic changes, flutamide, liver function test, finasteride, no specific laboratory monitoring is needed in healthy women, metformin in the beginning and 2 monthly thereafter, monitor plasma lactate level, peripheral blood film for megaloblastic anemia. Now, this table shows life factor and their management studies. After giving systemic and topical conventional treatment for the acne, we should counsel the patient about the lifestyle modifications. So, diet should be rich in high fiber diet, low glycemic index food, food rich in omega-3 fatty acid and gamma-linolenic acid. Stress, implement stress management techniques such as yoga, meditation, regular exercise. Sleep should be proper, 7 to 9 hours per day and daily. Skincare cosmetics, use non-comedogenic, gentle pH balanced skincare products and avoid harsh scrubs that cause irritation. Avoid over cosmetic use. Smoking, quitting smoking can improve both skin health and overall well-being. Physical activity, maintain an active lifestyle and cleanse the skin thoroughly. Thank you. That's all from my side.
Thank you, Dr. Dheeraj, for that wonderful presentation. Anybody has any question? Okay, we can now wind up the session. Thank you, Dr. Dheeraj.
Thank you, sir, for the wonderful session. I'd request our speaker and chairperson to please collect the memento. Now for the next session, I'd request Dr. M. Mukhtar, sir, and Dr. P.C. Das, sir, to please come on the stage.
The next topic is the ever-changing phase of treatment in psoriasis. The speaker is Dr. Subhamoin Yogi. Please welcome and deliver your presentation.
Good morning all. First of all, I would like to thank the scientific and organizing team of CUTICON BIHAR 2025 for giving me a chance to speak on this topic of ever-changing phases in treatment of psoriasis. So, the management of psoriasis has evolved a lot in the last 2 decades, starting from the broader non-specific immunosuppressive agents to more targeted approach. It has evolved a lot from the various topical therapies, phototherapies, systemic non-biologic agents like methotrexate, cyclosporin, to the newer biologic agents and oral small molecule inhibitors. So, before delving deeper into the discussion, I would like to highlight briefly the immunopathogenesis of psoriasis. So, we can see that after certain triggers like certain drugs, infections and trauma, the keratinocytes, the stressed keratinocytes, they release the self-nucleotides and the antimicrobial peptides, which then form a complex and activate the plasmacytoid dendritic cells, which then release interferon alpha, interferon beta. The keratinocytes also release TNF alpha, interleukin 1 beta and interleukin 6. They together activate these mature dendritic cells, which are the most potent antigen presenting cells. They travel to the nearby lymph nodes and present the antigen to the naive T cells, from where the adaptive immunity takes part. They release various cytokines, key cytokines like interleukin 12, TNF alpha, interleukin 23, which stimulate the proliferation and differentiation of the naive T cell phenotype to the Th17, Th22 and the Th1 phenotype. Now these Th1 cells, they release interferon gamma and TNF alpha, the Th22 release IL-22, the Th17 release interleukin 17 and 22. So these are the key mediators involved in the pathogenesis of psoriasis. The interferon gamma and TNF alpha, they again stimulate the mature dendritic cells, forming a feedback loop. The interleukin 17 along with the TNF alpha, they stimulate the proliferation of the keratinocytes, causing epidermal hyperplasia. Also, they release certain chemokines like CXCL8 and CCL20, which just bring more inflammatory cells like neutrophils, T lymphocytes, dendritic cells and macrophages into the inflammatory milieu of psoriasis, and a cycle of chronic inflammation is maintained. Now, coming to the various therapy in psoriasis, starting with the evolution of biologic agents in psoriasis. The older biologic agents which were approved for the management of psoriasis were alefacept and ifalizumab. They mainly targeted this antigen presentation and co-stimulation of the naive T cells by the myeloid dendritic cells. They inhibited this pathway. But gradually they were withdrawn from the market because alefacept has a limited PASI 75 value of 33%, and ifalizumab was withdrawn in 2009 due to its fatal side effect, progressive multifocal leukoencephalopathy. Now coming to the newer biologics, which form the backbone of the treatment of psoriasis nowadays, the TNF inhibitors, IL-12, the IL-17 and the IL-23 inhibitors. We have seen that TNF alpha acts on multiple steps on the pathogenesis of psoriasis. The interleukin 12-23 inhibitors, they inhibit both the interleukin 12 and the interleukin 23. Interleukin 17, they inhibit the interleukin 17, which are released not only by the Th17 cells but also the gamma delta T cells and various other cells like NK T cells, etc. And last of all, the IL-23 inhibitors, they inhibit the P19 subunit, which is specific to interleukin 23. Now coming to the various TNF alpha inhibitors in the management of psoriasis, etanercept was the first to be approved in April 2004. But it is gradually being phased out from the management of psoriasis because it has a lower PASI value of 49% at week 12. It has less potency for skin clearance, but its safety profile is better compared to the other TNF alpha inhibitors. It can be used particularly in children and geriatric population. It has the lowest risk of LTBI reactivation among the TNFIs. Infliximab, it is the intravenous drug used. It has the highest short-term efficacy for rapid response, but at the same time there are higher risk of developing neutralizing antibodies, higher chance of infusion reactions and other serious side effects, although they are less, but congestive heart failure, multiple sclerosis, they are the side effects. Adalimumab, again it is one of the first line agents with concomitant psoriasis and psoriatic arthritis. It has a high efficacy, PASI 75 values are 71 to 80% at week 16. And certolizumab pegol, which was FDA approved in May 2018, it has a certain advantage of that it lacks the FC segment of the antibody, so it doesn't cross the placenta, and thus it is safe in pregnancy and lactation. Now coming to the next generation biologics, the IL-12/23 inhibitors, ustekinumab and bryakinumab was developed. Ustekinumab is used. We have seen that these inhibitors, they act on the common P40 subunit shared by both the interleukin-12 and the interleukin-23. Thus, they inhibit the Th1 signaling as well as the Th17 signaling. It was approved for the management of psoriasis in September 2009. One advantage of this ustekinumab is that it has a weight-based dosing regimen. And the Phoenix 1 and 2 trial data, which is a placebo-controlled trial, showed that the PASI 75 values are around 66.4 to 75.7%. And it was seen that the higher PASI clearance was seen with the higher dose, that is the 90 milligram dose. The PASI 90 values are modest, around 37 to 40% and 11 to 13%. But it is a slower acting agent. The PASI values gradually increase from the week 12 to 23. Serious adverse effects like serious infections, major cardiovascular event and malignancy were much less in long term. Now this is a phase 3 trial, the ACCEPT trial, comparing the efficacy of ustekinumab and etanercept. At week 12 it was seen that the ustekinumab outperformed etanercept. Now coming to the next generation biologics, that is the IL-17 inhibitors, secukinumab, ixekizumab and brodalumab. So before the advent of these IL-17 inhibitors, rather after the advent of these IL-17 inhibitors, the PASI 90 and the PASI 100 values, the therapeutic goal has changed from the PASI 75 to PASI 90 and PASI 100. Secukinumab was approved in January 2015, ixekizumab in March 2016. Secukinumab and ixekizumab, they bind to the IL-17A, which is the most potent isoform of IL-17 and thus inhibit them. Brodalumab, it is IL-17 receptor inhibitor, thus inhibits the action of all the IL-17s. Now coming to the various trials comparing the efficacy, secukinumab at week 12, it was shown that the PASI 75 values are high, from 75 to 80%. PASI 90 values are in the range of 50 to 60% and PASI 100 values in the range of 20 to 30%. Ixekizumab at week 12, we can see that it has a greater efficacy, greater PASI 75, PASI 90 and 100 values compared to secukinumab. Brodalumab, we can see that the PASI values are identical to ixekizumab. Now, in this trial, the fixture trial comparing secukinumab with etanercept, it was seen that the PASI values were much better and statistically significant in comparison to etanercept. And there was higher incidence of candidiasis in the secukinumab group and injection site reactions were common with etanercept group. Now, there is another long-term trial of 5 years. It was shown that secukinumab has a brilliant long-term efficacy and safety over the years. Now another RCT, the CLEAR trial comparing secukinumab with ustekinumab, it was seen that again the PASI values were much better and all the other parameters like the IgA response and DLQA response were better with secukinumab. Now another trial, the IXORA-S trial comparing ixekizumab with ustekinumab, you can see that at week 12 there is a significant difference between the PASI values, but gradually at week 24 the PASI 75 values, the difference is decreased, but the PASI 90 and 100 values there is a significant gap. So we can see that ixekizumab has a much better efficacy than ustekinumab. Now among the IL-17 inhibitors, this study showed that between secukinumab and ixekizumab showed a trend towards faster and higher PASI 75 and 90 response. Now the newest kid in the block is bimekizumab. It is a dual IL-17A and IL-17F inhibitor approved for psoriasis in October 23 and for psoriatic arthritis in September 2024. It has a rapid onset and durable efficacy. It significantly outperformed secukinumab and other biologics in various trials. but the higher incidence of the oral candidiasis is there. And look at the PASI 100 values. It has a 76.2% PASI 100 value at week 52. Now coming to the next generation biologics, the IL-23 inhibitors, ustekinumab and brayakinumab, they inhibit the P40 subunit. The interleukin-23 inhibitors, they act on this P19 subunit specific to IL-23. Thus, they inhibit the Th17 signaling, but the Th1 signaling is paired. So, interferon gamma production is maintained, and thus efficacy against various intracellular pathogens is maintained. These are the various IL-23 inhibitors. Now, this trial showed that the comparison of PASI values among the IL-12-23 and IL-23 inhibitors, we can see that it is based on the various trials. The PASI 100 and PASI 90 values were much better with guselkumab, with risankizumab in comparison to guselkumab, and trildracizumab and ustekinumab had a similar efficacy. Now, another head-to-head trial comparing ixekizumab with guselkumab. At week 12, we can see that the PASI 90 and 100 values, there is a significant difference, but at week 24, there is not much difference between these two agents. Now, I will skip on these biosimilars. Biosimilars in psoriasis, they have the main problem with the biologics is the cost of therapy, but with the advent of the various biosimilars, we have seen that their efficacy is near equivalent to the originators. Drug survival is similar. Safety, they maintain the safety standards of the original molecule, and the most important advantage is the significant cost saving. And currently we have the TNF alpha and the IL-12-23 biosimilars available. Now I will skip these things. Now coming to the next things, the JAK-STAT signaling pathway in psoriasis. The various interleukins, they act on the various cells through these signal transduction pathways, that is the JAK-STAT. And we can see that IL-12, IL-23, IL-22, they mainly act through the TYK2 and JAK2 pathway. Now, this TYK2 signaling is very important for the IL-23 Th17 axis, and the recently developed deucravacitinib, which is a selective TYK2 inhibitor. It is FDA approved for plaque psoriasis in September 22. The dose is 6 milligram OD. It has superior PASI responses than other JAK inhibitors. It is well tolerated, but the cost of therapy is a major limiting factor. In this trial, Poetic PSO1 trial, we can see that there is significant difference between deucravacitinib and apremilast. Now, the next generation, the GLP-1 receptor agonist, this is a very hot topic. It is currently used for the management of obesity and diabetes, but it is gradually being also used in patients of psoriasis, which are obese psoriatic patients with concomitant type 2 diabetes and other cardiovascular risk factors. They reduce the body weight, improve the glycemic control, also reduce the various inflammatory markers. These are the various GLP-1 receptors. Now coming to the newer topical therapies, tapinarof, it has a unique mechanism of action, aryl hydrocarbon receptor agonist. In the trials, it has shown that it has a significant efficacy in mild to moderate psoriasis. It is FDA approved in May 2022 for the management of mild to moderate plaque psoriasis. These are the various images from the soaring trials. Another topical, newly approved topical agent is topical. Yes, sir. Give me more minute, sir. Topical roflumilast. It is a phosphodiesterase 4 inhibitor. The 0.3% cream formulation is FDA approved in July 22. The foam formulation is recently approved in May 2025 for use in scalp and body. Now, coming to the IL-36 inhibitor, we know that the pathogenesis of de novo pustular psoriasis is little bit different from plaque psoriasis in that there is hyperactivation of the IL-36 signaling in generalized pustular psoriasis. Pesolimab acts on this. It is the IL-36 receptor inhibitor, inhibits the signaling of IL-36. And in the EFICYL-1 trial, it was shown that with 900 milligram single IV dose, 84.4% of patients with moderate to severe generalized pustular psoriasis had no visible pustules on the skin after 12 weeks of treatment. Now these are the future directions: the IL-22 inhibitors, interferon alpha inhibitors, the ROR gamma T inhibition, and the S1PR1 agonist ponesimod. So with this, I end my topic. Thank you all.
Thank you, Dr. Shubhaman Yogi. You have very elaborately discussed the biologics and these newer drugs. For the time given, it was quite an exhaustive one.
Thank you.
So which of the biologics are safe in pregnancy?
So certolizumab and etanercept, they are only the category B. Others, the safety is not yet proven.
Among the IL-17 and 23?
There are no trials, so their efficacy in safety in pregnancy is not yet proven. Only with certolizumab and etanercept, they are only the category B drugs.
Okay, thank you.
Thank you. Thank you.
The next topic is dermoscopy, a new clinical stethoscope or just an academic luxury. There has been some change. Who is the speaker? So may I invite Dr. Akash Agrawal to speak on the same. Initially, this was a debate actually. One of the speakers has not turned up. So Dr. Akash Agrawal will speak in his favor.
Very good morning to respected chairpersons, seniors, colleagues, and my dear juniors. So I'll be speaking on this topic, that is a dermoscope, a new clinical stethoscope, or just an academic luxury. And I'll be speaking against the motion. So unfortunately, Dr. Amit Shekhar sir couldn't be here due to some personal reasons. And it would have been really a good debate, I feel, on a very burning topic. And I'd just like to disclose that I own a dermoscope and I use a dermoscope in my practice. And I'm not an expert, so it's just my honest take on what I feel regarding dermoscopy, whether it's a clinical stethoscope or an academic luxury. Right, so this photograph represents something that is very historic. That is, 200 years ago, a scientist named Lenach, he devised this instrument which today has come to be known as what is the stethoscope that we use. And this represents what a doctor is. When we think of a stethoscope, we think of a doctor with a stethoscope around him, right? And that is what it is. It's a symbol of healthcare for the last 200 years. And why a stethoscope is an indispensable tool is because it has a universal use. It is indispensable in every case. So any patient, you do an examination, you have to use a stethoscope. It is objective, it is reproducible. It improves clinical outcomes, which has been proven by randomized controlled trials, right? So now coming to dermoscopy. So around 2 to 3 decades back, when the dermoscope came up in the Western literature, it was basically to diagnose atypical nevi and to rule out melanoma. And the hope was that it would help move from an invasive biopsy to a non-invasive tool and reduce the need for a biopsy. It will hopefully improve clinical accuracy, it will guide treatment and prognosis, and it will be a screening tool. Well, have we reached that? Probably by the end of this presentation, we can come to a conclusion. So I'll be starting off with the case. So a 54-year-old man presented with this solitary elevated reddish lesion over the volar aspect of the left forearm of 4 years duration. I'm pretty sure everyone of you must be thinking, okay, this looks like a granulomatous lesion to me, right? So I also thought along the same lines. This was probably the two differentials that I thought. One was lupus vulgaris and the other was sarcoidosis. The dermoscopy was a bit surprising. So on the left, you can see the non-polarized contact dermoscopy. It shows certain scaling. You can see a whitish reticulate stria resembling a Wickham stria-like appearance. And on the right side, you can see follicular plugging. Right. So this was the dermoscopic findings. And in fact, the dermoscopic findings were suggestive of a condition known as lichen planus hypertrophicus, because this is what classically lichen planus hypertrophicus looks like. So would you like to change your diagnosis? So what happened was, this patient was treated by me like lichen planus and he did not respond. So when he came back, we did a biopsy for this patient, and to our surprise, it came out to be a frank case of lupus vulgaris. So we looked into the literature whether anything like this has been reported, and we came across this entity known as pseudo-Wickham stria, right? So something that is so pathognomic of a condition like lichen planus, that is a Wickham stria, can be mimicked in other conditions such as prurigo nodularis, a discoid lupus erythematosus, or a nodular scabies. Similarly, there are certain other things in dermatology which are very classic, such as, I'm pretty sure anyone who has done dermoscopy in psoriasis will say to me that uniform dotted vessels is diagnostic of psoriasis. What if I tell you that some conditions like erythroplasia of curette also has similar findings? Yellow serous crust, again, we only think of eczema, but herein is a patient who has pityriasis rosea with the typical colorative scale with yellowish serous crust. What I want to highlight is that these things are not universal, and when dermoscopy came through, these were propagated to be universal. So this is something that we should be knowing when we do dermoscopy. Again, pityriasis rosea has this colorative scale with a inner free edge. Other conditions also have this, such as psoriasis and tinea corporis. So again, this has to be kept in mind. Granulomatous disease. Whenever we think of granulomatous disease, we use a glass slide, we see the apple jelly nodules, yellowish in color, we think, okay, we are dealing with a granulomatous disease. Same with the dermoscopy. What if I tell you there are other conditions such as reticulohistiocytosis and parapsoriasis, wherein also you get this yellow color. And it has been said that you get this because of a mass effect of the dermal component of the disease, right? Even there are case reports of patients having granulomatous disease, wherein in dermoscopy there was no yellow color seen. So again, something which was 100% positive, not so now, right? Coming to this next case scenario. Okay, so this was a 45-year-old man who presented with this hyperpigmented brownish macule since 3 months. On the right side is the dermoscopy being shown. He was a doorman by profession, and which is important in this case, right? So on the dermoscopy, does it ring any alarm bells? So you see this parallel ridge pattern. Okay, I'm pretty sure all of you must remember that in acral melanoma, this is again a diagnostic sign. You get the parallel ridge sign. So, okay, yes. So we went ahead and the biopsy was done in this patient, and to the surprise, there was no proliferation of melanocytes, melanin granules that was observed. There was only big cells with pycnotic nucleus and abundant cytoplasm seen in the epidermal layer in a pegytoid spread. So this was actually friction induced. So the IHC was negative. This condition is what is known as pegytoid dyskeratosis. So it is secondary to friction. So there was nothing related to melanoma. And you might say, okay, the color is brown, but acral melanoma may start off as a brown pigment, right? So again, this has been documented, parallel ridge pattern in pegytoid dyskeratosis. It's a dermoscopic pitfall. In fact, there are many conditions on the palms and soles which can have a parallel ridge pattern. These are few of them. So on the top left is an acral melanoma. On the right side is a hematoma. Bottom left is an ink stain. And then on the bottom right, it's a benign nevi. So parallel ridge pattern not equal to acral melanoma. So earlier it was said it's 99% specific for acral melanoma. Is it? It's not. There are other limitations of tumors. So this was an article published in the JDV, which is a very top-rated, highly indexed journal. And they said that tumors, using a dermoscopy, it has a very high false positive and a false negative rate. So certain tumors such as SK, angiomas, dermatofibromas, adnexal tumors, they can look like malignancy. They can give a false positive. So what happens is that ultimately you end up doing a biopsy or an excision, which was probably unwarranted on clinical look, and it increases the morbidity and increases the cost to the patient. Right? So I'll just show you some examples of the same. So these both photographs are of seborrheic keratosis. So whenever we think seborrheic keratosis, we think of the dermoscopic findings such as milia-like cyst, comedon-like openings, brain-like structures, moth-eaten borders. But because of the pigment, sometimes these things can get obliterated. So this is a photograph of a solar lentigo and melanoacanthoma. Both are types of SK. But you don't see any features suggestive of the same. In fact, when you see this, you might think, okay, are we dealing with a melanoma? Right? Then certain adnexal tumors, this is well documented that trichoepithelioma and sebaceous hyperplasia may mimic a basal cell carcinoma on dermoscopy, again warranting unnecessary biopsies and adding to the morbidity of the patient. So if you thought false positive was dangerous, what is false negative? What about false negative conditions? Something that is a BCC looks like a benign condition. So it has medico-legal consequences again. So non-pigmenting BCC has been documented to look like dermal nevi. You have heavily pigmented BCC which appear like blue nevus. You have certain well-differentiated SCCs that look like benign keratinizing tumors. So you have to keep this in mind when you're doing a dermoscopy. It's not an absolute, right? Okay. Now coming to certain trichoscopic pitfalls. So this is dermoscopy from the same patient of two different areas. The patient had alopecia areata. Right side you get black dots, left side also you have black dots. Difference is on the left they are not actually black dots, these are environmental debris. So they are what are called as dirty dots, and on the right side are the dots of alopecia areata. So alopecia areata, black dots means disease activity. Environmental dots, debris, that is dirty dots, means nothing. So one is an artifact, one isn't. Secondly, both the pictures look similar. Both look like regrowing hairs. What if I tell you the left side is actually hair fiber that the patient is using to cover up his alopecia? Right side is the regrowing hair. So looks very similar, right? Now, if I just give you this dermoscopic image, probably you'll end up doing a biopsy in this patient. And you'll be shocked to know that this is just hair dye that the patient has applied. So context, clinical examination followed by dermoscopy is very important. Whenever you do a trichoscopy, shampooing before doing a trichoscopy is very important. So what's holding back dermoscopy? What are the problems that dermoscopy has? I think first and foremost is a cost factor. I'm pretty sure, I think there are 20-25 odd people here, and I'm pretty sure hardly 5 or maximum 10 of us would be having a dermoscope right now, purely because it is an economic burden. Do you get a ROI on a dermoscopy? Does it help you in diagnosing majority of cases that you see in your OPD? Probably not. So this is just a small comparison. So the basic dermoscope, that is the Hine Mini 3000, costs about 50,000 rupees, and the Dermlite costs in the upward in the range of 1.5 lakhs. Whereas a stethoscope, just for the comparison sake, maximum a Littmann costs about 8,000 rupees. So you can understand why this comparison looks a bit, you have to get the cost down if it has to be used by all. Second thing, it's operator dependent. It's something like an ultrasound. So if you know how to do it, you know about it, then you very well may use it in your day-to-day practice. It has a steep learning curve. The problem is, because it is so new, many of us don't have an idea through our learning about dermoscopy. Like I passed out a few years back, so dermoscopy was part of my curriculum, so I am doing it now. What about people who have passed 15 years back or 20 years back? So there needs to be an upgradation on the skills of everyone so that dermoscopy can be more widely used. There is a high inter-observer variability. What might look like red dots to me might look something different to you. So there is no standardization yet. Misinterpretation is very common, and it is not ideal for high OPD centers. So it takes 2 to 5 minutes per patient. So do you have this much amount of time when you are dealing with a huge OPD load? Though this is something that is very important. So this was a paper that was published. It's a compilation of named metaphorical terminologies in dermoscopy. So we all have heard about these metaphorical terms that have been used in dermoscopy. So I just feel that, it's attractive. When dermoscopy came up, it was something very new, and it was a good, area for publications, for academics. So it led to a lot of publications with no standardization. So you came across this terminologies like beauty and the beast sign, isobar sign, honeycomb-like pigment network. So all this is, it is up to your imagination. Something like might look like an orange to me, it might look like a sun to you. So it's how you describe it, and that adds to the confusion. So the list is endless. Now, can dermoscopy actually replace a biopsy? I don't think so. It cannot actually assess the depth or architecture. It can never confirm atypia. It will always remain gold standard. So to sum up what I was saying, this was actually a survey done by a group of researchers among dermatologists in India, wherein they found that of the people who responded to the survey, 54% were only doing it. So approximately it was sent to 1,000 dermatologists. 150 responded, out of which 75 are using dermoscopy. So you can actually imagine the number is not 54%, it is probably 7% or 10% of us who are using dermoscopy. And they feel that only 10 to 12% of your cases in OPD require a dermoscope. And what are the major limitations? Lack of training being the highest. Second is the cost. Then they are not convinced of the utility and the lack of time. So to conclude, again, I come up to this hype and hope with dermoscopy. So has it reduced the need for biopsy? I think still biopsy is the gold standard. Whenever you have a doubt, you have to go for a biopsy, and you cannot rely on dermoscopy yet. Does it improve clinical accuracy? To an extent, yes. Does it guide prognosis and treatment? We don't have much real world robust data. We don't have clinical trials with a sensitivity and specificity to say that, okay, this is what we are dealing with. And can we use it as a screening tool? Again, high false positive and false negative rate. So herein what my point is with regards to dermoscopy, and the road ahead is that we have to understand it lacks the universality of a stethoscope. I can understand from where it's coming. It is something that we can call our stethoscope, because we don't often use one. You require robust RCTs. You require strict standardization and following the same. So the international consensus on dermoscopy, they have come up with standardized methods by which you can actually describe dermoscopic findings, but there needs to be a strict implementation so that for future publications, at least those are used, so that there is symmetry in what people understand. There must be structured training courses, and it is best to use dermoscopy only on a case-to-case basis, wherein it's required, and not do dermoscopy in all cases. So with that, I would like to conclude my talk, and I would like to sincerely thank the IDVL Bihar branch, Dr. Vikas Shankar sir, Dr. Svetlina ma'am, Dr. Abhishek Jha sir. Thank you so much for inviting me.
Well, do we have any questions? Okay, thank you, Dr. Akash.
Thank you, sir.
I congratulate you for preparing so nice against dermoscopy.
Thank you, sir.
Well prepared, well delivered. Thank you, Dr. Akash.
Thank you, sir.
Again.
Thank you so much.
Thank you, sir, for such an interesting discussion. I'd request our chairpersons and speaker to please collect the mementos. Coming up to our next session, Innovations in Dermatology, I'd like to invite Dr. Alok Kumar sir on stage for chairing the session.
Please come Dr. Archana Lokhande, ma'am, for the presentation of artificial intelligence and digital dermatology shaping the future of diagnosis.
Hello, very good morning to all the respected chairperson and delegates who are present for this presentation. Today I'll be talking on artificial intelligence and digital dermatology, how it is shaping the future of diagnosis. So coming to the why this matter to our practice. There is rising disease burden, or the people are getting more aware about the skin conditions. So we need to augment our diagnostic skills for more accurate, more accessible diagnostic support. And the world is changing digitally very fast. So AI is not a replacement, but it can be used as an integrated tool to improve accuracy, access, and efficiency of our clinical skills. Why dermatology fits for AI? First and foremost important, as dermatology being an image-rich specialty. It is so ideal for the deep learning. There is pattern recognition which aligns with the CNN models. So current tools like teledermatology platforms, mobile apps, digital dermatoscopy, and whole slide imaging are the toolkits what we have. So teledermatology platforms are getting raised day by day. It is a backbone for the assess. AI has been integrated for an intelligent triage, prioritizing the urgent cases, especially in case of oncology. The digital dermatoscopy. It provides the high resolution standardized images which are essential for the sequential monitoring. So the digital dermatoscopy is also an essential tool for the teledermatoscopy. Coming to the applications of AI in healthcare, as we all know, radiology, medical robots, adaptive treatment planning, clinical trials, pharmacology, digital patient record, and much more. So coming to the key AI technologies in the dermatology, as we all know, convolutional neural networks, that is CNN, natural language processing, or the generative AIs. Coming to the clinical application of AI in dermatology, so we'll be discussing one by one all of them. Skin cancer detection, inflammatory skin diseases, analysis of skin biopsy, like histopathology, tissue samples, gene profiling, AI-assisted chatbots, or in cosmetic dermatology, hair nail analysis, and most important, clinical decision making. So first, coming to the oncology, where the AI application has been used extensively. CNN could be used for the triage, like deep learning algorithms help in dermoscopic differentiation in melanomas, nevus, and it can also help in the body photography and sequential dermoscopy, which flags the new or evolving ugly duckling lesions. The models are increasingly becoming efficient to identify between BCC or SCC, and also help in differentiating benign keratosis from the inflammatory lesions. So it can also be helpful in the management of digital pathology, especially in the most microscopic surgeries, where the digital histopathology slides can be used for the intraoperative margin assessment and reducing the processing time and improving the efficacy. It can help in prognosticating the histopathology slide depending upon the mitotic rate, and the genomic data could use to predict the metastasis risk. It can thus help in the treatment monitoring, non-invasive imaging to clarify the tumor clearance during the non-surgical treatment. Coming to the other inflammatory disorders like psoriasis. So it has been said that psoriasis can be accurately diagnosed 84 to 100% by the AI models, and especially for the inverse psoriasis. It can support the diagnosis and also help in tracking the prognosis of the disease. So basically it can be used for education, like ability to present accurately the information on psoriasis, precision medicine, where the medicine has been directing henceforth. So optimizing an individual treatment plan, finding out the biomarkers which can be used to monitor the disease activity, severity, and diagnosis of the patient. So it is also used extensively in the psoriatic arthritis. The machine learning uses the genetic marker to distinguish psoriasis and psoriatic arthritis. It is important for the accurate diagnosis for the, of the coexisting condition, and thus help in guided, targeted, and effective treatment plan. while also on the biological therapy, AI model can analyze the severity, demographics and clinical history, genetics in forecasting the biological treatment. So individualized tailored treatment, which could be trial or error free. So this is just a pictorial representation of multiple diseases like psoriasis, vitiligo, hidradenitis suppurativa, rosacea, acne, oral lichen planus, alopecia areata or atopic dermatitis. Most of the places it can help in lesional counting, severity scoring counting. So AI enhances the diagnosis and management of these diseases. The lesional counting software outperforms the manual method, and it facilitates the personalized treatment and improved patient outcome. So especially in acne or rosacea, the lesion counting help in severity grading and for objective treatment monitoring. Same with the atopic dermatitis, the severity scoring and tracking treatment response via patient submitted images becomes easier. So there are multiple patterns which help in recognizing the conditions and differentiating it with the other similar looking conditions. Coming to the AI in hair diagnosis beyond trichoscopy. So the analysis of the trichoscopic images has become automated with the help of AI. The parameter quantification has become easier with the AI algorithms, which help in counting the follicular units, hair shaft diameter variability, or the villus hair. It also helps in the pattern recognition. Multiple models assist in differentiating the different patterns of alopecia like AGA or alopecia areata or telogen effluvium by identifying the key markers. So while it is when humans are like observing the patterns, there could be inter-observer variability, which is generally avoided with the help of AI models. Objective severity scoring, like it provides a standardized repeated scoring to objectively track the disease progression. So AI has been used vastly in the hair transplant areas also. Robotic assisted FUE use the computer version of the precise follicular unit selection, extraction. Thus, it minimizes the transaction rate of the hair follicle and even helps the surgeon to do the things better and faster. It can also predict the response in the modeling. So it helps in analyzing the patient data and predict the likelihood of the response treatment, whatever we are using. It helps in the remote monitoring and adherence to the treatment with the help of teledermatology. Coming to use of AI in nail disease detection and management. So different CNN help in differentiating the nail conditions like onychomycosis, psoriasis, or melanoma. It has the accuracy of almost more than 87%. It automates the severity scoring. There are multiple smart imaging tools which help in localizing the nail abnormalities. Nail fold capillaroscopy, which is a part of dermoscopy, also becomes useful with the help of AI. So dermatoscopic differentiation of multiple capillaroscopy or the inflammatory condition or infectious condition becomes easier. In case of melanomas, it helps in the dermatoscopic patterns when used by the AI to analyze. It helps in giving the better decision while aiding the biopsies. Objective scoring. Now, automated calculation of the nail psoriasis NAPSI index helps in standardizing the assessment. Similarly, while the patient is on the treatment, it helps in measuring the response and monitoring. Now, histopathological correlation, as we have already discussed, it can also help the predictive biomarkers with the help of integrated AI with the genomic data. Now, coming to the aesthetics, there are digital shift in the aesthetics. So AI-powered skin analysis, there are multiple apps we have been knowing, and patients are coming with those, use of those. So objective matrix, it helps in quantifying the wrinkles, pore size, pigmentation, textural changes from the clinical imaging. Subsurface detection, it The concerns like UV damage before they are clinically evident could be help in planning the therapies. Standardizing tracking, it enables the consistent objective monitoring of the treatments. And so these are the examples of how AI has been used, and different skin damages could be quantified with the help of AI. Managing patient expectations. So even in the hair transplant or while doing any kind of procedure, we can give a visualized idea to the patients to manage their expectation. So AI-driven 2D or 3D stimulations helps to show the potential results of procedures like fillers, rhinoplasty, or body contouring. So it enhances the consultation as it provides a powerful visual aid. So improving the patient communication, it becomes easier for dermatologist or any aesthetician to give an image to the patient and convince them what is going to be expected. It also helps in making the informed decision and realistic aesthetic challenges. AI has been also integrated in the energy-based devices like lasers or RF devices, and it allows the real-time feedback on the skin temperature, tissue response, ensuring the safety and more effective treatment. So we can adjust the energy delivery based on this monitoring, which is crucial for all skin type. Now coming to the data-driven recommendation. So depending upon the analysis data, we can suggest the optimal evidence-based treatment modality for a particular patient. There is intelligent modality selection. So among the procedures available like lasers, injectables, topicals, or combination therapy, the models can predictively depending upon the specific phenotype, they can recommend what are the modalities which are more helpful. And we can also optimize the parameters of the devices. Now, how we can use this AI like in our workflow? So these are real-world AI platform or tools which we can use and which helps in monitoring of the disease. Now, so in the teledermatology or when patients are at remote location, it helps in follow-up. It can help, algorithms can help in early detection of subtle signs of complication, and it can also help in tracking the adherence of the patient. So there are multiple ways we can use AI, like patient triage or booking, automated charting, or image management, or as well as the billing or other clinical, non-clinical stuff. Now coming to the ethics, what does this say? There could be algorithmic bias, like it is critical for skin of colors, especially in Indians or Asians. The models are more trained, not yet trained for the non-diverse database. So there could be the disparities between it. So we must demand or validate the local data. Coming to the data privacy and security. So it's up to us how we are using these platforms and how is the security of the platform. De-skilling and over-reliance. So AI is just a supportive tool. It is not a replacement for a dermatologist. We must guard against the black box and always apply our clinical skills and validation. Medical, legal, and accountability. So if the AI is wrong, who is responsible? So AI is just a tool. Now what could be the future of AI in dermatology? So there could be wearables, 3D imaging, AR-assisted care, predictive dermatology, and obvious the personalized healthcare. So there is generative AI and LLMs, predictive dermatology, and AR-assisted care. So we are moving to more of personalized and dermatological care. What are the challenges or practical issues? So teledermatology outrage, mobile adaptation, need for the local data reflecting the skin tones, which is most important, and clinicians should be trained enough. Now this is the implementation roadmap. Education and training is the most important to overcome the barriers. Clinicians should accept these new tools and engage in AI ethically and proactively. So dermatologists, plus AI. We are the collaborators, not competitor. We should focus more on empathy, ethics, and expertise. And last and foremost is AI just provides the data. The dermatologist provides the diagnosis, the dexterity, and the empathy. It is our clinical judgment that matters. Thank you very much to the AI tools, and thank you for your patient listening, and thank you very much, CUTICON BIHAR, for giving me this opportunity. Thanks a lot.
Thank you, doctor. Any question from audience? Next topic is PDRN, the basics and its application in dermatology. The presentation is Dr. Palvi Kashyap, consultant dermatologist, Patna.
Hello everyone, a very good morning to the Honorable Chairperson and my seniors and delegates who have come here to listen to this session. So, PDRN, the basics and its application in dermatology. What is PDRN basically? Polydeoxyribonucleotide, basically a mixture of DNA fragments and which is derived from salmon or trout sperm. It acts as a tissue repair and regeneration stimulant in dermatology and aesthetics and known as commonly salmon DNA therapy or DNA skin booster. So what is the mechanism? Polydeoxyribonucleotide basically enhances the skin regeneration and healing through activation of adenosine A2A receptors, DNA salvage pathway, and secondary cellular effects like antioxidant, microcirculation improvement. So adenosine A2A receptor activation is basically the PDRN is degraded into nucleotides that bind to the A2A receptors on skin cells, results in anti-inflammatory, angiogenic, and regenerative responses. Basically decreases the pro-inflammatory cytokines like TNF-alpha, interleukin-6, interleukin-1 beta. And the vascular endothelial growth factors are increased, leading to angiogenesis and improved oxygenation, and increases the fibroblastic activity, which leads to collagen and elastin synthesis. DNA salvage pathway provides nucleotides and nucleosides as a raw material for DNA synthesis, supports cell proliferation and repair in the damaged skin cells, accelerates keratinocytes and fibroblasts regeneration, and promotes faster wound closure and epidermal turnover. And the secondary cellular effects improves the extracellular matrix, composition and hydration, reduces oxidative stress and reactive oxygen species, enhances microcirculation, that is better nutrient and oxygen supply, leads to brighter, more resilient and evenly toned skin. So the pharmacological properties, it is regenerative, anti-inflammatory, angiogenic and antioxidant. So its application in dermatology, we can use it as anti-aging and skin rejuvenation for wound healing, acne scars and PIH, hair regeneration and atopic dermatitis. So in skin rejuvenation, as I discussed, it improves the skin texture, elasticity, hydration, stimulates fibroblast proliferation and extracellular matrix remodeling, used for fine wrinkles, dull skin, post-acne scars and photoaging, and the delivery method is through mesotherapy, microneedling or skin boosters. Again, wound healing, as it promotes epithelialization and angiogenesis, leads to speeds recovery, then we can give it in the post-laser peel and surgery patients, and is effective for chronic ulcers, burns, and post-surgical wounds as well. In case of acne scars and post-inflammatory hyperpigmentation, it stimulates tissue remodeling, reduces inflammation, commonly combined with microneedling, PRP, or hyaluronic acid. Then improves the scar depth and skin texture as well. In case of hair regeneration, it enhances the dermal papillae cell activity, improves scalp microcirculation and hair density, useful in androgenic alopecia and telogen effluvium. In case of atopic dermatitis and chronic dermatosis, anti-inflammatory and regenerative actions, reduces redness, irritation, promotes barrier repair, adjunct therapy with moisturizers and topical steroids. So the formulations and delivery can be in the injectable forms, topical serum or creams, often combined with hyaluronic acid or the growth factors, and administration is every 2 to 4 weeks. We can have 6 to 7 sessions depending upon what condition the patient is. Again, the safety and side effects, generally it's safe and biocompatible. Mild transient erythema and swelling may occur. No systemic toxicity or allergic reactions are reported and derived from purified non-immunogenic DNA fragments. There are various studies which are done on PDRN recently which actually focus on mechanism, safety, molecular mechanism, and different indications of PDRN, scar, wound healing, then comparison of PDRN with polynucleotide, and again polynucleotide and adjunct with the fillers in clinical aesthetics. So, but there are certain research gaps which need to be taken care of because since PDRN is quite new when it comes to aesthetics. So growing clinical data for wound healing is present, but in aesthetic dermatology, the data is very heterogeneous. There is major gap between standardizing of the dosage, formulation, then comparison. Larger random control trials need to be done to actually prove the efficacy and the use of the PDRNs. Then head-to-head trials need to be done. Again, PRP and hyaluronic acid, comparison of PRP and hyaluronic acid along with PDRN has to be done. What in future directions we can do, multi-centric RCTs can be done, then again biomarker-driven studies should be done, formulation optimization and acceleration of the non-salmon PDRN sources as well. So we conclude that PDRN is safe, effective, regenerative, promotes collagen synthesis, angiogenesis and tissue repair, useful in anti-aging, wound healing, acne scars, alopecia, represents a promising approach in aesthetics and clinical dermatology. But PDRN exists in India. It is not clear that it's fully regulated as a drug or a product with full approvals. There are some regulatory uncertainties when it comes to PDRN, and there's no much division whether it's a drug, device, or a cosmetic usage. Again, the Central Drug Standard Control Organization approval needs to be checked whenever you are taking any PDRN. Either it's a device or in the drug form, or you're using as mesotherapy or injectables. Then again, whether the label which is claiming to be PDRN has some approvals or not, whether the manufacturing, import and marketing licenses are approved or not. So finally, we can conclude that PDRN can be used along with different other like PRP and hyaluronic acid for further skin rejuvenation and wound healing, but a lot has to be done and studied yet to actually make it into a complete reliable therapy. Again, thank you so much, CUTICON Bihar and all my seniors to give me this opportunity to speak upon this platform. Thank you so much.
Thank you, Dr. Pallavi Kashyap, for wonderful presentation. Any questions from audience? Thank you, doctor.
Thank you, sir.
Thank you so much, ma'am, for highlighting such a new and innovative topic. I would request our chairperson and speaker to please collect their mementos. We are going to have a 15-minute tea break and we will get to the session after that. session.
Good morning, doctors. Now, a very interesting topic on acne and anti-age treatment, microneedling with radio frequency. It is presented by Shivangi Singh. Shivangi Singh, please come on the dais. Shivangi Singh is assistant professor and lot of presentation and publications. Over to Shivangi Singh.
A very good morning to all the delegates. I am going to talk upon microneedling radiofrequency, its application in acne scars and aging skin. So I'll be covering the topic under the heading of background, understanding the MNRF technology, its physics, the microneedling collagen induction formation, combined MNRF synergistic mechanism, MNRF in acne scar evidences and outcomes, MNRF for anti-aging, its mechanism and results, MNRF procedure and protocol, its safety, tolerability, limitations and the references. So why MNRF matters? We all know that acne targets the dermal collagen, leading to atrophic scar mostly rather than hypertrophic scar. And aging skin also shows the signs of collagen loss, elastin degradation, reduced dermal thickness, leading to fine lines, wrinkles, skin laxity, and uneven skin texture. So traditional treatments which are available like lasers, chemical peels, dermabrasion, subcision, fillers have limitation in the form of increase in downtime, risk of hyperpigmentation, especially in a darker skin tones, and limited efficacy for deeper scars and laxity. So there is a need for minimally invasive, versatile procedure, one that can address both scar remodeling and skin rejuvenation, and MNRF offers such possibility. So what is MNRF? MNRF is microneedling radiofrequency, which is a minimally invasive dermatological procedure which combines both fractional microneedling with bipolar or monopolar radiofrequency energy delivery. It is a synergistic approach. It targets the dermal collagen to stimulate neocollagenesis and tissue remodeling. So understanding radiofrequency energy emission is nothing but an alternating current of approximately 1 to 4 megahertz which generate electromagnetic wave that penetrate the tissue, and the tissue resistance here by the dermal tissue, it converts RF energy into thermal energy. It leads to heat zones formation, which is a controlled thermal zone of around 60 to 70 degrees centigrade at a targeted depth, especially 0.3 to 3.5 mm, creating microcoagulation columns, followed by collagen denaturation, which is immediate collagen fiber contraction, followed by neocollagenesis and elastin remodeling over 3 to 6 months post-treatment. Now, what microneedling does is it causes collagen induction by forming micro injuries inducing the fine needles like 0.5 to 3.5 mm depth, triggering the wound healing cascade. As we all know, there are 3 distinct phases, that is inflammatory phase, proliferatory phase and remodeling phase. Inflammatory phase start within 24 hours, leading to release of growth factors like PDGF and TGF-beta. Proliferatory phase starts from day 5 to day 21, where there is fibroblast activation and type 3 collagen deposition. It is followed by remodeling phase, which start from 3 to 12 month post-treatment, which is collagen type 1 replacement and dermal matrix reorganization. This procedure maintains epidermal integrity whilst maximizing dermal remodeling, which is a key for minimizing the downtime. So how both technology help us? Both technology act as a synergistic mechanism where we get the precise depth control. The microneedle delivers RF energy directly to the target depth, bypassing the epidermal damage and ensuring uniform thermal distribution, leading to enhanced safety profile. profile, unlike the ablative lasers, MNRF preserves the stratum corneum, which reduces the risk of post-inflammatory hyperpigmentation, particularly crucial for skin type 4 to 6. Dual stimulus effect in the form of mechanical trauma from needle combined with the thermal energy amplifies the wound healing process, resulting in superior collagen remodeling compared to either modality alone. So there are various devices available, and these devices are classified depending upon the type of the needle and energy configuration. So we have two kinds of needles, insulated needles and non-insulated needles. Insulated needles, they form focal thermal zones in deeper dermis, thereby reducing the epidermal heating. And non-insulated needles, they have a broader thermal effect, which is suitable for superficial treatment. Depending upon the energy configuration, we have monopolar systems and bipolar system. Monopolar system is used for deeper tissue penetration and is used for substantial tissue remodeling, whereas bipolar system is more superficial and provide controlled heating. So it is preferred for sensitive areas like periorbital and perioral areas. So MNRF has been used in several studies for acne scar, and so there are few studies which I am quoting. So the study by Chandrasekhar et al. Has shown that there was 80% improvement in more than 2 scar grades, and majority have moderate to good improvement. Similarly, study by Navya Devi et al. In 2024, she studied in Indian skin types of post-acne scar, where also significant scar improvement, good safety profile was noted. In addition to that, there was skin tightening and skin rejuvenation. Similarly, systematic review also shows that there is improvement in skin in the scars, and there is dermal remodeling progressive continuing up to 6 months post-treatment. So to summarize, MNRF offers consistent, significant improvement in atrophic acne scars with good patient satisfaction, acceptable safety profile, and minimal downtime, and suitable for darker skin types. Now, MNRF for anti-aging mechanisms and result. So in anti-aging, the MNRF helps by collagen remodeling. The thermal injury stimulates the fibroblast proliferation, which thereby regulates type 1 and type 3 collagen synthesis, which is also demonstrated histologically by several studies. And it is followed by upregulation of heat shock protein, which increase the expression of elastin, thereby increasing the elasticity of the skin, particularly effective for periorbital and perioral rhytides. And it also helps in immediate tightening. So collagen fiber contraction would occur instantly at 60 to 70 degrees centigrade, provide visible lightening and tightening. Long-term neocollagenesis sustain improvement for 12 to 8 months post-treatment. So there are comparative studies which reveal that MNRF achieves similar wrinkle reduction as compared to fractional CO2 laser, but the downtime is significantly less in MNRF as compared to CO2 fractional laser. So few studies which has been done for skin aging are by Kaur et al., where RF was used with microneedling in skin laxity and wrinkle patient, and they have demonstrated visible improvement, and histological evidence of dermal remodeling was also noted. Similar, the study by Kaplan et al. Also used the global aesthetic score, where more than 50% improvement was seen in 43% patients, and more than 25 to 50% improvement was seen in 80% patient. MNRF was also tried in Asian skin, where Asian skin patients were treated with MNRF, and the wrinkles, the skin laxity was reduced with minimal adverse effect. To summarize, MNRF improves wrinkles, skin laxity, texture, and overall skin quality over months. Efficacy is seen even in sensitive areas like periorbital area and in darker or Asian skin type with acceptable safety and minimal downtime. Progressive and cumulative improvement is also seen, where dermal remodeling seems to continue for months after treatment. So how to proceed with the procedure? Beforehand, we have to select our patient depending upon the Fitzpatrick skin type, scar tendency, and active infection. We have to exclude the patient having pregnancy, having pacemakers, or active acne, followed by taking informed consent. Prior to the treatment, we have to take photographs of the affected area, and we have to map the area priorly to the procedure, and we have to prep the area with the help of a topical anesthesia, which is applied under occlusion for 45 to 60 minutes. Then we have to set a device depending upon the need. For example, for fine lines, the needle depth has to be kept for 0.5 to 1.5 mm. For moderate acne scars, it has to be 2 to 2.5, and for deep, it is 3 to 3.5. And energy has to be adjusted between 15 to 40 watts. Treatment execution has been done in a stamp technique where 20 to 30% overlap is done with 1 to 2 passes for facial rejuvenation and 2 to 3 passes for acne scars. We have to avoid excessive passes to prevent thermal damage and prolonged erythema. And immediate post-treatment, we have to do the cold compresses or apply cooling gel, followed by topical antibiotic ointment. And we have to advise patient for strict sun protection and apply sunscreen of more than 50 SPF for 2 weeks. And the follow-up schedule has to be at an interval of 4 to 6 weeks. So talking about the safety or tolerability, the adverse effect is mild and transient erythema and edema and mild pain which resolve without serious issues. Limitations with the modality is that dermal remodeling and full aesthetic benefit take time. Optimal results often need multiple sessions, for example 3 to 6 sessions. For very deep or tethered or ice pick scars, we have to combine MNRF with subcision or any other modality, and long-term data on durability of anti-aging effects is still limited. These are the references. Thank you for the patience hearing.
Nice presentation, Shivangi.
Thank you, sir.
Any questions from audience? Okay, thank you.
Thank you, sir.
Thank you, ma'am, for such a wonderful session. I would request our speaker to please collect her memento. For the final session of the day, I would like to invite Dr. Shwetalina Pradhan ma'am and Dr. Punkesh Kumar sir to please chair the session.
So our next speaker is Dr. Aditi Snehal. She is currently assistant professor at NIMC Sasaram, and she did her SRC at AIMS Patna. She had lot of presentation, dynamic young dermatologist. So Aditi, welcome.
Thank you, ma'am, for such kind words. So today I'll be talking about a very viral therapy, which is very popular amongst all the influencers and Bollywood actors and actresses. We often see in their beauty regimens, they have a mask over their face, which has a red light over them. And it is very popular for, they say that for my skin, glowing skin, they use it. And before, obviously, the makeup session, they have their half an hour session of this mask. So as my PPT has been started, so the therapy name is low level laser light therapy. This is a very popular name for the low level laser light therapy is the core laser. As this laser doesn't cause any heating or any kind of irritation over the skin as other ablative lasers. So this is called a cold laser or a soft laser. So my scope of discussion will be the principle and mechanism of this therapy, the ideal wavelength and the dosing, the review of the clinical indications and the evidence related to it, the safety profile, contraindications, and the future directions and patient protocol, what should be done before the therapy and while the therapy, and the takeaways. So this is a laser with a red or a near infrared light, which has a wavelength of 600 to 1000 nanometer and a low power of usually a 5 microwatt, but it can extend up to 500. The alternative names I have already said, but photobiomodulation is also a name which is very commonly used in the Western society. So the key characteristic for this laser is that this is non-thermal. So when a patient uses it, it does not cause any heating effect on the skin. Plus it's non-ablative, the other tissues have no effect, so there is no tissue destruction around it. It stimulates the mitochondrial activity and helps the rejuvenation factor. So the main characteristic is, because of the being famous for this therapy, is that it is non-invasive. So a very convenient therapy which a patient can use on their home also. A very low intensity light is used to stimulate the cellular activity of the targeted skin. So it is used for a variety of indications, for skin rejuvenation, wrinkling, acne scars, hair loss, in that also androgenetic alopecia, very popularly used nowadays. And the main factor is it is also FDA approved. So FDA approved treatment means that it is therapeutic and it gives positive results. So the cells are exposed to a low level of red or near infrared light, which delivers, this skin is absorbed by the photons, and the photons deliver to mitochondria. As we know, mitochondria is the powerhouse of the cell and it produces ATP. So the ATP obviously will be beneficial in every aspect. So they activate the cellular process, ATP generation, so rejuvenation, nitric oxide increase, blood circulation increase, collagen production, tissue repair, everything is a byproduct of ATP generation. So as we discussed, a range of 600 to 900 or 1000 nanometer of wavelength is used in this therapy, which is a red and a near infrared zone. The chromophobe is the cytochrome C oxidase, which absorbs this photon, and these are the primary photoacceptors, and which delivers to the mitochondria. So as we, only this range is targeted because the maximum depth or penetrating factor is present with this range, as we can see from 650 to 950. The principle is, as the photons are absorbed, the photoacceptors, cytochrome C oxidase delivers it to mitochondria, and this mitochondria increases ATPase, which increases cellular energy. There is reduction of the inflammatory markers, there is activation of growth factors, and so there is anti-inflammatory properties as it decreases IL-8, IL-18, and there is increase in IL-10, that is also anti-inflammatory, and increase in TGF-beta. So there is improved microcirculation, reduced oxidative stress over time, hence there is reduced inflammation. So the stepwise, as we know, discussed, the photoreceptors absorb it. There is increased electron transport, increased mitochondrial membrane potential, increased ATP synthesis. There is increase in nitric oxide, increase in calcium, and transcription factors activation present, and gene expression for healing occurs. So there is protein synthesis, cell migration, anti-apoptotic properties, growth factors upregulation, stem cell activation. There is two type of basically laser or the light which is used. The most common is diode laser, which maximum penetration for 6 to 10 mm with 630 to 700 wavelength. So what we use maximum for acne, antibacterial property is achieved with blue light. We are discussing the red light, but it also has a range with blue light. For acne, we use antibacterial, which acts on P acne, that is 415 blue light. And red, as discussed. There is also a green light, which we use in cellulitis. We'll be discussing further. The dosing will be maximum in most of the cases. We do it 3 times per week, that is alternate day, for half an hour, and the maximum, the initial effect which can be seen is after 12 weeks. So the indications in which these therapies used is, first of all, obviously skin rejuvenation, then acne, photoprotection, vitiligo, fat reduction, psoriasis, androgenetic alopecia, depigmentation, hypertrophic scars, and keloid also. So very famously used in androgenetic alopecia, as people doesn't want the combustion of minoxidil applying every day, the compliance is less, or they don't want to pop in all tablets of finasteride. So this new therapy is non-invasive. They think that this will have no side effect, and it has a very good safety profile. So what we say to the patient is, they have to wear a cap or a helmet. These kind of helmet, combs, hair bands are available, which deliver red light. It is recommended to apply it for alternate days, half an hour every day, while they do their early morning activities. They can do it. It is a non-detachable, like there is no electric plug is needed for it. Patient can use for themselves also. The only miss point is it's very costly, and if you have the exact nanometer and wavelength, it costs about 1 lakh. But obviously, where India is there, Jugaad is there. So we also get a 5,000, 10,000 one caps and hair bands present, but that doesn't work very properly. So the 6 months to 12 months, the whole therapy full results is seen after 1 year, but alternate day or twice a week is recommended. So these are a result done for a Thai study, in which the initial studies where a very good in androgenetic pattern hair loss was seen, a very good hair rejuvenation. So it's a pain-free treatment. That's why it is very popular. There is increase in the anagen hair, and it is equivalent to minoxidil. That is, minoxidil also has a 20 to 25 hair growth per square centimeter square, and it has about 15 to 22. So it's a very good, and the best part is we can have it in a combination therapy. So if you are giving it to any patient with minoxidil and finasteride, you can give them, this is a popular and a very hand therapy for the patients. They can do it themselves. So it can be combined with any therapy which you are giving. Only risk factor is, there is no major side effects or risk factors. There is initial telogen shedding, that is all the hairs which are in telogen that will be out, and can be in very few patients, burning, irritation and folliculitis can occur, but very few. The next indication is skin rejuvenation, where a wavelength of 633 to 830 nanometer is done. For wrinkles, pigmentation and rejuvenation, very popular for this indication also, as it increases the collagen. The collagen type 2, 3 is increased, and the circulation as the nitric oxide increases, so the circulation is also increased, so having a rejuvenation properties. These are the mask which is very present popularly. A whole clinic setting red light therapy is like this is also very popular, but this the patient can have it on their own. This one we can have in on our clinicals, so this is a bit costly one. So many studies have been performing this, and a significant improvement, as it can be seen in the photos. The wrinkles have vanished, a little bit minor wrinkles are present. So a 1 year therapy, that is 12 session, gave this result. So the advantage, as I have already said, it's non-invasive. The downtown is very, very minimal. Like after the procedure, there is no effect on the face and the patient can carry their life properly, even with everyday treatment. It's safe, affordable, and FDA approved. It can be combined with chemical peels, IAPL lasers, retinoids, which have synergic effect and less post-treatment erythema. So the next is acne vulgaris. As I said, the blue light is used that is antibacterial properties, and the red light with anti-inflammatory properties. So if we combine both them, blue and red, the combination therapy is very synergistic and very good for the acne vulgaris. We give 2 sessions per week, including for most of 4 weeks session with alternating blue and red light. Obviously, we can give only one wavelength once. So we give one session, we'll give blue light, and the next session we'll give red light. So many studies, this is the study, the first picture, there are a lot of acne, and in the last picture, it is very significant improvement. It has also been in 660 nm for melasma and pigmentation also. By it increases the microcirculation, collagen remodeling, and the melanin burden is decreased. So a Massey score reduction of equivalent or more than 65% has been seen after 12 sessions. So with very good safety profile, no repigmentation seen afterwards. So this is, as we can see in the photos, a good decrease in the pigmentation in the melasma patient is seen. It can also used in targeted therapy. So this therapy was first used for decreasing the inflammation. So in ortho, in healing process, targeted machines were designed where it decreased the inflammation, causing, so the same properties also used for psoriasis where a lot of inflammation is present. So a combination of 630 and 830 is combined, and it used mostly for the recalcitrant psoriasis, adjuvant therapy with good results. So here is a treatment before and after. So these type of targeted machines can be used for the red light. It has also been used for fat reduction. So transitioning micropores, as it causes, and these pores stimulates the release of intracellular lipids from the adipocytes, and basically it induces the adipocyte apoptosis, which results in intracellular lipid components, but the apoptosis of the adipocyte causes the fat reduction. So this is the machine which can be used, the whole body machine, or targeted can also be used. The A is very targeted and B is the whole body. Same as in cellulite, but wavelength of 532 is used, where the diode has green light, and this is a kind of a machine which is used. The chamber is there, and with significant improvement with the same also. So body contouring is also done, is non-invasive, and 635 to 680 nanometer wavelength is used. 30 minutes twice a week treatment is there, and the results is good with safety profile. So these are the machine. A whole room of infrared light can also be prepared. With obviously the cost is very high, but it is used very rampantly in Western countries. So it has also seen improvement in hypertrophic scars and keloids, and vitiligo also with a 632 nanometer wavelength. It increases the growth factors in the keratinocyte, causing melanocyte stimulation, and 6 to 8 session with 60 to 70% of the repigmentation is present, mostly used for segmental vitiligo. Wound healing, as we suggested, it was invented for wound healing and decreasing inflammation. So collagen synthesis, neovascularization, decrease inflammation, increase fibroblast is there. And it is also used in herpes labialis recurrent cases where patient is very irritated with the again and again coming. So others are for the decreasing the pain, inflammation, and it has a very good safety profile. with evidence-based indication are skin rejuvenation, acne, melasma, and vitiligo. And obviously, we have to do it in a clean face and a maintenance even after 1 year for monthly basis is also advised. The future studies are going on and it's still happening for the same, as it's a new and a very costly treatment. So my takeaway points are that this is a very safe drug, very easily done in the clinics, and fetches a very good revenue also. Very popular among the youths, so can be tried. As it is FDA approved, so it has a claim. There is a stimulation of healing, reduction in inflammation, reduction in cell death, skin rejuvenation is present. There is mitochondrial activity, increase in ATPase, increase energy. So it is a good therapy, and I hope those who are present over here will try this therapy in their clinics. So these are my references, and thank you so much. I would also like to thank the organizing team, especially Svetlina ma'am, for having me here. Thank you so much.
Thank you so much, Dr. Aditi.
That was a wonderful session, ma'am. I would request our speaker to please collect her memento. So we will be starting our ABGM at 12 noon exact. So I would request our delegates to gather around in the hall at that time.
A very good afternoon to all. Now we are going to start our AGBM, and before starting I would request kind correction. Now for the beginning we will start with valedictory. I would like to call upon the stage organizing chairperson of 39 CUTICON BIHAR, Dr. Abhishek Kumar Jha sir, co-chairperson Dr. Shwetalina Pradhan ma'am, organizing secretary Dr. Punkesh Kumar sir, scientific chairperson Dr. Vikas Shankar sir, scientific advisor Dr. Ravi Vikram sir, treasurer Dr. Rajneesh sir, scientific joint secretary Dr. Shivani Shekhar and Dr. Mubarak Hussain.
Jai Jagannath, as organizing chairperson of this conference, मैं आप सबको धन्यवाद देता हूँ आने के लिए। हम लोग भी टीम की तरह काम किया, गलतियाँ हमसे भी होती हैं, तो हम इसके लिए क्षमा प्रार्थी हैं जो भी गलतियाँ हुई, और हमें उम्मीद है कि आपने इस कॉन्फ्रेंस को अच्छे से इसमें जो पार्टिसिपेट किया और जो भी हम कर सके और जो भी हमारी त्रुटियाँ रहीं उसके लिए मैं क्षमा प्रार्थी हूँ एज ऑर्गेनाइजिंग चेयरपर्सन। अगली बार हम कोशिश करेंगे कि इसे बेहतर करें। धन्यवाद।
जय जगन्नाथ जी की। कॉन्फ्रेंस को सब लोगों ने पसंद ही किया, जैसा कहा हमारे ऑर्गेनाइजिंग चेयरमैन साहब ने कि त्रुटियां हो ही जाती हैं, तो हम लोग सब एक फैमिली हैं। आप लोग का पार्टिसिपेशन, सीनियर लोग का आशीर्वाद, कलीग्स का साथ, जूनियर्स का जो स्ट्रेंथ है, उससे मिल के आइडियल फैमिली तैयार होती है। फैमिली में कहीं कुछ कमी, कहीं कुछ बेसी, कभी किसी का मत अलग, कभी किसी का मत अलग, सबको लेकर चलने की कोशिश की जाती है। जो आज तक जो भी ऑर्गेनाइजेशन हुआ है, सबका साथ लेके ही चलने की कोशिश की गई है। सबका बात पूरा नहीं हो पाता है, सभी को मालूम है, लेकिन मेरे ख्याल से अभी तक इतने दिन में जो हम लोग यहाँ हैं, साइंटिफिक भी ठीक ही रहा होगा। आप लोग मेरे ख्याल से पसंद किए होंगे, और पसंद किया है तो उसके लिए बहुत बहुत धन्यवाद। कोई कमी है तो ज़रूर उसको रखा जाएगा। दूसरे बाहर से भी लोग आए, सब लोगों ने पसंद किया, नेशनल एग्जीक्यूटिव भी थे, तो हमारे तरफ से सबको बहुत बहुत धन्यवाद यहाँ पधारने के लिए और पार्टिसिपेट करने के लिए। और इसी के साथ जय आईडीवीएल, जय हिंद, जय बिहार।
Jai Jagannath. As a scientific chairperson, I thank my team who has tirelessly day and night worked for IDVL Bihar and making this conference CUTICON 39 CUTICON Bihar at Puri. And as a scientific chairperson, I take the honors if something has unintentionally gone not good. I take the responsibility of all the things unintentionally if are done not good. So I sincerely apologize for this. अगर कोई ऐसी त्रुटि रह गई हो हमारी ऑर्गेनाइजेशन की तरफ से, जब बड़े कार्यक्रम होते हैं, परिवार में कोई बड़ा सा फंक्शन या छोटा सा बर्थडे होता है, कभी कभी we miss something. So as a scientific chairperson, I take this honors and I say sorry if something happened like this. And I thank all the faculties, delegates, family members who have attended and graced this occasion. All the senior members of IIDVL as well as colleagues and juniors, PGs and pharmas for continuous support and this love to Bihar IIDVL. Long live IIDVL, long live Bihar IIDVL. Jai Jagannath.
अब मैं चाहूँगा कि मेंबर्स कुछ अपने विचार रखें। डॉक्टर वीरेंद्र सर, वीरेंद्र कुमार सिंह साहब।
किस पॉइंट पर वहाँ जाए? इस कॉन्फ्रेंस। गुड मॉर्निंग ऑल ऑफ यू। आज हम लोग क्यूटिकॉन 39 के समाप्ति पर वैलिडेटरी सेशन कर रहे हैं। मैं इस ग्रैंड सक्सेस के लिए पूरी 39 क्यूटिकॉन ऑर्गेनाइजिंग कमेटी और साइंटिफिक कमेटी को बहुत बहुत धन्यवाद देना चाहता हूँ। और मैं पिछले 1 साल से प्रेसिडेंट IIDVL रहा हूँ। मैं जब चार्ज लिया उस समय भी बोला कि सबका साथ सबको सम्मान। मेरी इच्छा यही है, मैं चाहता हूँ कि IADVL एक परिवार है, परिवार में हर तरह के लोग होते हैं और सभी की इच्छाएं, सभी का मत एक नहीं हो सकता है, लेकिन उसी में एक साथ लेकर चलना पड़ता है और चलना चाहिए। और हम तो यही कहेंगे कि एक बनो नेक बनो। हम लोग एक हैं, एक रहेंगे और जो भी मत भिन्नता होगी उसको एक साथ बैठ के सुलझाएंगे, यही हमारी इच्छा है। और आगे जो है उसके बारे में कुछ बोलना है अभी? अगला क्या? तू तो बोल दिए धन्यवाद।
Hello, good afternoon everyone. I'm extremely thankful to the organizing chairperson and the entire team for organizing a very well organized conference, extremely well planned, meticulously executed, and up to the new team will have a very tough time in matching the standards that you have set. I hope next year they will strive to live up to the expectations that you all have set. Thank you all once again very much. You all have been doing such a wonderful job since so many years that nobody could dispute the fact that it has been a very good journey, and I hope the journey continues in the right direction with the new team. Thank you so much.
सभी लोगों को धन्यवाद। बहुत अच्छा कार्यक्रम हुआ। मैं एक बात कहना चाहता हूँ, आप लोग कहते हैं गलतियाँ हुई, माफ़ कर दीजिए। इस धरती से, जगन्नाथ की धरती पर हम लोग हैं, यहाँ जो भी गलती हुई यहीं छोड़ के जाना है, सबको माफ़ी मिल जाता है। यहाँ से गलतियाँ लेकर नहीं जाना है। आगे से कोई इस तरह की बात नहीं कीजिएगा, मन में संकल्प लीजिए, बस गलती माफ़ हो जाएगी। हम लोग जहाँ हैं ये बहुत क्या कहा जाए, अभी के कलयुग के देवता नहीं हैं, ये स्वयं मौजूद हैं। उनके अंदर कृष्ण की शक्ति है। पढ़े होंगे आप लोग, तो जगन्नाथ जी जो है ना, वो लिविंग देवता है आज के समय के लिए। इसलिए गलती सही मत सोचिए, गलती सब यहाँ छोड़ के जाइए। और सब लोगों को बहुत बहुत धन्यवाद। चलिए,
जय जगन्नाथ, जय महाप्रभु। कॉन्फ्रेंस बहुत ही बढ़िया रहा, बहुत हर दृष्टिकोण से, जितने भी टेक्निकल या जो भी कर लीजिए, हॉस्पिटैलिटी, एवरीथिंग। और सर ने अभी गलती की बात की, गलतियां कॉन्फ्रेंस में माफ़ी के लिए नहीं होती हैं। अगर कुछ हो गया है तो उससे सबक लेके उसको सुधारने के लिए होता है, और इससे हुआ भी नहीं है। अगर है तो उसको सुधार के हम लोग नेक्स्ट बढ़िया से करें। थैंक यू एवरीवन, टू ऑल ऑर्गेनाइजिंग टीम।
Heartiest congratulations to the team, organizing as well as scientific, because every year the improvement what we have seen in Ayodhya, it's even better than Ayodhya conference also, and the participation from whole of country, that is very much a thing which is new to a state conference, and a mixture of younger people with experienced one. That's very nice. And the participation from this young team and the scientific program was also so much planned in a way that everyone got a chance to, either as a panelist, as a chairperson, as a speaker. So everyone got a chance. So many congratulations, and next coming years we'll try to improve, and we'll try to match and go far beyond this, with this level. we'll try definitely. Congratulations to everyone.
CUTICON के सभी मेंबर्स, ऑर्गेनाइजिंग मेंबर्स को बहुत बहुत धन्यवाद, क्योंकि ये कॉन्फ्रेंस बहुत ही वेल ऑर्गेनाइज्ड था, साइंटिफिकली भी, और जो सब लोगों को जो कनेक्ट किया गया अदर स्टेट के लोगों को, ये बहुत अच्छा लगा। बहुत लोगों ने पार्टिसिपेट किया, लग रहा था कि एक नेशनल कॉन्फ्रेंस है, ये एक बिहार का कॉन्फ्रेंस नहीं लग रहा। इसके लिए आप सब लोग धन्यवाद के पात्र हैं, और आगे हम लोग चाहेंगे कि इसी तरह इसको बढ़ाया जाए। थैंक यू।
जितना भी अभी हाल फिलहाल के दौर में कॉन्फ्रेंस हुआ है, चाहे जनकपुर में हुआ हो, अयोध्या जी में हुआ, या बनारस में हुआ, आज पुरी में हुआ, सब जगह तो हम लोग धर्मभीरू आदमी जनकपुर जा रहे हैं, माता सीता के धाम का दर्शन करेंगे, अयोध्या जाएंगे, भगवान राम के ध्यान का दर्शन करेंगे, बनारस जाएंगे, बाबा विश्वनाथ का दर्शन करेंगे, यहाँ जगन्नाथ जी आए हैं, जगन्नाथ स्वामी का दर्शन करेंगे। सबसे बड़ी भावना तो वही रहती है। उसके साथ कॉन्फ्रेंस, सब तो सोना में सुहागा था, कहीं कोई त्रुटि नहीं, कहीं कोई गलती नहीं है। फिर भी अगर थोड़ा देर के लिए लगा हो, लेकिन हमको कोई ऐसा नहीं लगा कि कॉन्फ्रेंस में कोई गलती हुई है, या ऑर्गेनाइजेशन अरेंजमेंट में कोई गलती हुई हो, या किसी भी तरह की व्यवस्था में कोई खामी हमको नज़र नहीं आई। जय जगन्नाथ।
आप सभी को मैं सबसे पहले तो ऐसे टीम को बहुत बधाई देना चाहता हूँ सक्सेसफुल कॉन्फ्रेंस के लिए। और जो कि सर बोले कि बिल्कुल लग रहा था कि नेशनल कॉन्फ्रेंस हो रहा है, और मैं चाहता हूँ कि हम लोग भी इसके अगला आईडीवीएल नेशनल लेवल बिहार में किया जाए। जैसा कि आप लोग का टीम है, बहुत ही एफिशिएंट, बहुत ही मेहनती लोग हैं, एंड बेस्ट ऑफ लक टू ऑल ऑफ यू।
मैं इस अवसर पे एक चीज़ और कहना चाहूँगा कि एक नेशनल कॉन्फ्रेंस होता है ओनाइकोकॉन, जो 26 से 28 दिसंबर तक पटना में है, और ये हमारा कॉन्फ्रेंस है। हमें बिहार को ये नेशनल कॉन्फ्रेंस मिला है। मैं आप सबसे आग्रह करूँगा कि आप उसमें ज़रूर आएँ। और एक आईएल का कॉन्फ्रेंस है फरवरी 27, 28 और 1 मार्च को एम्स पटना में, जो भी नेशनल कॉन्फ्रेंस है। तो आप लोग सब समय निकाल के, क्योंकि ये बिहार का कॉन्फ्रेंस है, ये हमारी इज्जत की बात है कि हम नेशनल की कर रहे हैं, तो आप सबसे आग्रह कि उसमें ज़रूर सम्मिलित हों, और साइंटिफिक में पार्टिसिपेट करें, एकेडमिकली पार्टिसिपेट करें, और ऑर्गेनाइजेशन में पार्टिसिपेट करें। धन्यवाद।
ये एक स्टेप अहेड है कि हम फ्यूचर में नेशनल कॉन्फ्रेंस को ऑर्गेनाइज कर पाएंगे, चाहे वो डर्माकॉन ही क्यों नहीं हो। वी आर लर्निंग विथ टाइम, और आई मस्ट से कि एक एक बूंद से ही घड़ा बनता है, एक एक बूंद से ही समंदर बनता है, और इसी से फिर स्टेट भी बढ़ेगा हमारा। आप सबों में जो भी हमारे बिहार के रिस्पेक्टेड आईडीवीएल मेंबर्स हैं, उनसे ये आग्रह करता हूँ कि आपको साइंटिफिकली कुछ भी, चाहे वो नेशनल नेल सोसाइटी ऑफ इंडिया हो, चाहे वो IAL हो, इंडियन लेप्रोसी एसोसिएशन हो, उसमें अगर आपको साइंटिफिकली किसी तरह से पार्टिसिपेट करना है, आप हमें बताएं। अगर आप नहीं बताएंगे तो फिर ऐसे सबसे पूछा ही जाता है, बट चूँकि ये आईडीवीएल ग्रुप का नहीं है, इसलिए बहुत सारा चीज़ आईडीवीएल ग्रुप में डिसेमिनेट नहीं होगा। बट आप तो जो प्रेसिडेंट हैं आईडीवीएल को, उनसे मैं परमिशन चाहूँगा कि इस मैसेज को आईडीवीएल ग्रुप में भी डिसेमिनेट करें हम लोग, क्योंकि ये बिहार की चीज़ है जो बिहार नेशनल कॉन्फ्रेंस लेवल पे जा रहा है। तो आप सबों से आग्रह है कि आप आगे आएँ, अपना इंटरेस्ट दिखाएं, और पूरी तरह से हम लोग के साथ सहयोग करें, ताकि हम लोग प्रूव कर पाएँ कि ये जो हमारा बिहार है, आर्यावर्त का जो धरती है, इसका कोई जोड़ नहीं है, और बिहार इज़ द बेस्ट। B means Bihar and B means best. So I invite every person of Bihar to let's take this opportunity to a step forward to make our Bihar dermatologist, anybody, become the best. Thank you so much.
धन्यवाद आप सबका। अब हम रिक्वेस्ट करेंगे कि जो लोग भी बिहार के लाइफ मेंबर हैं, वही इस हॉल में रहें, क्योंकि हम अपना EGBM स्टार्ट करेंगे, और बाकी लोग लंच के लिए प्रोसीड कर सकते हैं। धन्यवाद। सिर्फ लाइफ मेंबर्स ही काइंडली यहाँ पे रहें।